Good morning, everyone, and thank you for joining us. My name is Bryan Boehringer, and I'm the CEO of the Oregon Medical Association. Before we get started, I hope that everyone is safe and healthy, and I want to thank all of you for everything that you're doing to help get us through this pandemic. I also want to acknowledge all of you that have been impacted by the terrible wildfires and let you know that we're thinking of you. With that, I'm pleased to welcome you to the OMA's Annual Conference, Medicine Now, Leadership in a Time of Transformative Change, presented virtually for the first time. Because we have such a compelling lineup of speakers, we will keep our introductions brief so that we can devote as much time as possible to our programming. Our full speaker biographies can be found by clicking on the conference link on the OMA website. Staff will also add that link to the chat. There will be a limited time for questions after the presentations. If you would like to ask questions during the session, please use the Q&A box to do so. The chat function will also be enabled so that you can comment throughout the presentations. If you experience technical difficulties with Zoom, please contact Dan Joyce at dan@theoma.org for assistance. And with that, let's get started. I am very delighted to introduce the moderator for our conference, Dr. Elizabeth Lahti. Dr. Lahti is a clinical educator and hospitalist in the Division of Hospital Medicine at OHSU. She also serves as the Director of Narrative Medicine in the OHSU School of Medicine, where she teaches narrative medicine and reflective practice with a particular interest in identity formation and resilience through story. She also serves as the current president of the Northwest Narrative Medicine Collaborative. I would now like to invite Dr. Lahti to introduce the conference and our speakers. Dr. Lahti.
Thank you, Bryan, and good morning to all of you wherever you are, whether you are in your Saturday best or still in your pajamas, having that first cup of coffee. This is my first virtual conference, and so I am looking forward to learning together. I'm thrilled to be joining you today for the Oregon Medical Association Annual Conference on Leadership in a Time of Transformative Change. And the times indeed have changed since the last time we all gathered here last year. The COVID-19 pandemic, calls for social justice, and wildfires scorching the West have upended our occupations, our schools, our social lives, our relationships, and our practice of medicine. And they have exposed the structural inequities that have put diverse communities at a disadvantage for generations. In just a few months, we have had to learn new ways to work, learn, communicate, play, connect with loved ones, and examine the painful disparities of our past and present. Today, we will not only discuss how to try to make sense of it all, but more importantly, how we can rise to meet the challenges and opportunities brought about by the forces that have so profoundly disrupted our ways of life. We know the challenges we face, but how do we look beyond the despair to build an aspirational healthcare system and a broader society that are sustainable and authentically equitable for all? We are in a time of transformation. It is a time to reevaluate and to reimagine. It is a time for leadership. Our speakers today are all innovators in their respective fields, serving on the front lines in their health systems, in public health, in healthcare administration, and in developing state and national policy. Through their stories, examples, and vision, we will learn how to evolve into leaders in our communities and our professions. And together, we can forge a transformative pathway into the future for all Oregonians. Today's speakers will appear in pre-recorded videos of their presentations, but they will be live for moderated questions at the conclusion of their presentations. If you have questions for the speakers, click on the Q&A box at the bottom of your screen, and we will collect those questions as the speakers are presenting and offer them for a conversation after their presentations. Before we begin, I'd like to introduce the sponsors who made this conference possible. A special thank you to CNA, the Partners Group, and Northwest Permanente. You will hear from each briefly throughout the conference. Thank you again for joining us today. And now it is my pleasure to welcome Dr. Kevin Ewanchyna to present the State of the OMA Address and welcome for the annual meeting of the association. Dr. Ewanchyna is the Chief Medical Officer for Samaritan Health Plan Operations, and he currently serves with great distinction as the Oregon Medical Association President.
I am very pleased to present today's State of the OMA remarks. Last September, when I was honored to accept the mantle of the OMA presidency, I was inheriting it from a man I greatly admire, Dr. Fred Williams. Due in part to Dr. Williams' efforts, the association formed the OMA Equity Task Force soon before I was installed as president, and I was glad to pick up the torch that they helped light. It was a timely call to action as the task force addressed gender equity and equity and inclusion within the House of Medicine. This task force has also seen its goals shift and become more complex in 2020 due to our society's long overdue focus on issues of racial equity and social justice. And my hat is off to the task force's chairs, Dr. Jenny Silberger and Dr. Fred Williams. I am excited about the task force's ongoing work in this crucial arena at this crucial time. Your OMA has been very active with legislative issues, led by the very capable Courtney Dresser. The OMA has been engaged in monitoring the response to COVID-19 by the federal and state governments. The OMA continues to focus its engagement on ensuring clinicians have access to PPE and a reliable testing process, as well as access to relief funds to keep practices open. We're also focused on reducing unneeded administrative burden, ensuring providers have liability protection during this pandemic, and ensuring that patients have access to clinicians through telemedicine. The OMA is monitoring elections this November, including ballot measure 108, which would increase cigarette and cigar taxes and establish a tax on e-cigarettes and nicotine vaping devices. This measure would also fund necessary health programs. As a family physician and a parent of teenagers who are now young adults, I have noted with great concern the alarming growth of vaping among local youth. The Oregon Health Authority reports that 1 in 4 Oregon high schoolers has vaped. In the last year alone, vaping among Oregon youth increased by 80%. Research shows that young people who vape are almost 3 times more likely to start smoking tobacco. Big tobacco companies also know this, which is why they target youth with candy-flavored vapes and related advertising. I have seen firsthand, as you have, the adverse effects that vaping has had on young people in our community. Tobacco is the #1 cause of preventable death in Oregon. We all pay the price for tobacco use, $1.5 billion per year for smoking-related healthcare costs in Oregon, while tobacco companies continue to profit. Over the years, so many of my patients have told me that they regretted smoking as teens and how hard it is to quit despite their desire to do so. On a personal note, my own mother, who you may recall meeting last year at my installation, was diagnosed with lung cancer this past year, and she wishes now that she did not start smoking as a teen. The Oregon Health Authority and the OMA have continued to partner on the Steering Toward Health campaign, a multi-year initiative that aims to reduce the incidence of type 2 diabetes and other serious lifestyle-related chronic conditions, such as heart disease and stroke in Oregon. The Steering Toward Health effort focuses on reaching more of our state's 1.1 million adults living with prediabetes, a precursor to diabetes, and connecting them with evidence-based lifestyle change programs. To facilitate the process of detecting and treating prediabetes, the OMA and the Oregon Health Authority have co-created an online toolkit that offers research-based materials for healthcare providers and patients. The guide contains Oregon-specific resources, as well as the American Medical Association's best methods to screen and refer high-risk patients to diabetes prevention programs. Last year, the OMA launched a new digital newsletter, Public Health News, that highlights the steering toward health efforts and creates a space for community health dialogue. Last fall, we were also pleased to launch Mentor Match, the OMA's program that pairs early career physicians, physician assistants, and students with peak career counterparts for mentoring opportunities. In 2021, we anticipate growing the Mentor Match program. And finally, a few words about the coronavirus pandemic. As I wrote in April of this year, in an open letter to the people of Oregon, published by the Oregon Health Authority, Oregon's physicians, physician assistants, and other healthcare professionals have faced and are continuing to face an unprecedented challenge, perhaps the most urgent of our careers. We are all continuing to put ourselves in harm's way on a daily basis to keep Oregonians safe and healthy. We are also dealing with mental anguish on what we may unknowingly bring home to our families, and that is a huge challenge. But through collective action and collaborative teamwork led by CEO Bryan Boehringer and the extremely effective OMA administrative staff, the Oregon Medical Association has filled a vital role during the pandemic, serving and supporting physicians and physician assistants as they rise to this challenge. Throughout the pandemic, we've ensured that all physicians and PAs, regardless of membership, are kept informed by creating a COVID-19 webpage and near daily COVID-19 email updates. We're pleased that the feedback on these resources indicate that our COVID-19 communications are read widely, and the OMA appreciates the opportunity to serve our community in this arena. The association has quickly evolved into an authoritative voice in the state as we confront this moment. And I could not be more appreciative and proud of you and your work. Throughout the pandemic, the members of the OMA have hewed to scientific principles, steered clear of rhetoric, and applied themselves towards workable solutions. Thank you for that ongoing effort. I value your care, your compassion, your professionalism. But even at a time of crisis, both worldwide and here in Oregon with our recent wildfires, it's important for our community of physicians and physician assistants to take time for learning, sharing, and reflecting. And that's why I'm so very glad you've joined us here today. Welcome to OMA's Medicine Now conference. I hope you enjoy the event.
Thank you, Dr. Ewanchyna. I personally have been so impressed with everything that OMA has done over the past year, from tobacco and vaping to mentorship to the issues with equity, and of course, with the incredible communication around the COVID-19 pandemic. So thank you, Dr. Ewanchyna. I'm now pleased to welcome Director Pat Allen, who heads the Oregon Health Authority and who will provide our opening address, No New Normal, Promoting Health Equity in a Pandemic. Director Allen has over 25 years in public service, and his guiding principles at the Oregon Health Authority are to promote transparency, the wise use of public dollars, and integrity throughout OHA's many programs. If you have questions, please fill them in the Q&A box, and we will have the opportunity to speak with Director Allen after his presentation. Thank you.
Thank you. Oregonians are today confronted by the COVID-19 pandemic, which threatens the lives and livelihoods of people across the state. As physicians and healthcare providers, you're confronting the greatest health challenge we can expect to see in our lifetimes. In the same way, we're facing the greatest challenge of our lives as public health officials and healthcare policymakers at the Oregon Health Authority. At the same time, Oregonians are grappling with a national reckoning over systemic racism and inequity. As healthcare providers, this is an opportunity to confront and interrupt the unacceptable inequities communities of color have experienced in healthcare, just as we are reckoning with our responsibility to acknowledge and interrupt those inequities in our role as policymakers, payers, and regulators at OHA. Today, I'm going to talk about 4 things: how we define health equity, how the legacy of inequity in Oregon has affected people's lives, how the COVID-19 pandemic has laid bare these stark inequities in ways we can no longer ignore. And finally, I want to talk about what we're doing as a state to tackle systemic racism in our pandemic response. OHA's mission to help every Oregonian achieve optimal health and well-being and ensure access to quality, affordable health care has never been more urgent. But health equity has been our priority even before the COVID-19 pandemic, starting with our strategic plan. To fulfill our mission, OHA is developing a strategic plan with a singular overarching goal: to eliminate health equity in Oregon over the next 10 years. This strategic plan has been developed with the input of hundreds of Oregonians throughout the state, with a primary focus on listening to people from communities that have experienced health inequity and who our health system has failed to serve, as well as white residents. It's an ambitious goal, but we can achieve it by working with you and other partners. But before we get into how we're working to eliminate health inequity from our COVID-19 response, let's talk about what we mean by health equity. Let's go to the next slide, please. What I want to do now is do a little bit of definitional work and talk just briefly about the distinction between health disparities and health inequities. In simple terms, health disparities are differences in health that don't have an underlying issue that it calls for a policy response. Best example I can think of is the difference in birth weight between boys and girls. Boys on average weigh a little bit more than girls do. There's nothing about that that calls for action or indicates a particular problem. Health inequities, though, basically are unnecessary and avoidable. They're considered unfair and unjust, and usually they're rooted in social injustices that make some groups more vulnerable to poor health than other groups. Again, the best example I can think of here is infant and maternal mortality in Black mothers and babies versus white mothers and babies. Black mothers and babies die at significantly higher rates even after you've adjusted for income and educational levels. Let's go to the next slide. But what does health equity mean? In Oregon, we have a definition that establishes what we mean when we talk about health equity. And I'm not going to read through the definition here, but I do want to highlight some of the key terms. Health systems create health equity. Health equity and inequity are products of a system. Health inequities are not the products of personal responsibility. As providers and policymakers, we've got a profound impact on the health system. We have the ability to interrupt systemic racism or perpetuate it. As an example, when Oregon provided health coverage to every child, regardless of their immigration status, the state addressed a structural barrier that fueled health inequity among Latino families. Ongoing collaboration. Too often we treat health as if it's isolated from the larger social context. Instead, we need to address health in a broader social context. That means partnering with communities in different ways, addressing housing, education, food security, poverty, and other issues that account for 90% of the factors outside the doctor's office that impact a person or a family's health, in addition to the 10% that a provider can address. Redistribution of resources and power. We have to listen in new ways and genuinely share decision-making power. Historical and contemporary injustices. We have to recognize that the legacy of genocide and slavery still exert a profound impact on the health of Native Americans and African Americans, and take action to mitigate the health and social burden of these injustices. Next slide. Actually, the slide after that as well. So I'm not going to go into a great deal of data or of detail on these data slides, but what I do want to do is quickly share with you some data points to illustrate this notion of what these inequities are and how they track to past and present injustices and racism. Here, I've got 4 data points. The upper left-hand corner is adverse childhood experiences, ACEs. I'm sure you're familiar. And this is an indication of the fact that American Indian, Native Alaskan children are about 50% more likely to have suffered 4 or more adverse experiences in childhood. Graduation rates on the right side, substantially lower in the same population. Homelessness in the lower left, significantly higher among African Americans. Incarceration rates, vastly higher among African Americans. Next slide, please. Black and Hispanic Oregonians are less likely to have health insurance, and we're seeing the impacts of this play out in dramatic fashion, especially in the coronavirus pandemic, as access to and connectedness to not just insurance, but the primary care, particularly that insurance helps pay for, plays out in incredibly high infection rates amongst Latinos. Next slide. Many communities of color report higher average days of poor mental health. And this tracks, again, along the same kinds of lines of American Indians, Alaska Natives, Black Americans, Native Hawaiians, Pacific Islanders, all with significantly higher days of poor mental health. And what I want to point to across the bottom, we've identified some of the key drivers. And it's this pervasive notion of getting up every day and being faced with socioeconomic status, job issues, daily racism and encounters, and then particularly unequal access to healthcare services. Next slide. And this then is kind of the flip side of that, which is the ability to access behavioral health services. And here I want to call out linguistically and culturally appropriate services as a barrier. If you get east of the Cascades, it's incredibly difficult for a Latino individual or family to be able to get behavioral health services in their language in a way that respects what culturally works for accessing those services in their communities. Next slide. This is regarding aid and assist patients, and what this is a legal term, and it's people who have been arrested but are unable to participate in their defense because their mental condition makes them unable to aid and assist in their defense. And so they require restoration services before they can stand trial, if in fact they ultimately stand trial. And here, the point is that Black or African Americans are much more likely to be involved in aid and assist restoration services than others. Next slide, please. This indicates the challenge Black and Hispanic parents have in getting their children needed care. And this, believe me, is not because Black and Hispanic parents love their children less or recognize the need for care less. It really stems from access to, again, linguistically and culturally responsive services, access to payment through insurance systems, and then conscious and unconscious bias. I'm sure you've heard the story of Serena Williams and her experiences during childbirth, basically having a blood clot. She had blood clots before, recognized the symptoms, and couldn't get her caregivers initially to pay attention to her symptoms. Next slide. Finally, this is the one that is most profound to me and really kind of wraps everything up. This is a little bit of a wonky metric, but it's the years of potential life lost before age 75 per 100,000 people. So in a population of 100,000 people, how much premature death is there, and how significant is that premature death? And it's striking and tragic and shocking as you look at these numbers again of American Indians, Native Hawaiians, Black and African Americans who lose double the amount of life as white Oregonians. We've listed some of the major causes on the right-hand side, and really these track very closely to causes related to toxic stress. And so this is not sort of a matter, as I indicated in the beginning, of a bunch of bad personal choices for no reason at all. This is the accumulative burden over generations, in particular for these populations, of the impacts of slavery and genocide. Let's move to the next slide. So let's talk about the ways COVID-19 has made the inequitable health burden of people of color worse in Oregon. Next slide. This is stuff that I think we've all been hearing and reading about, but I want to show you the numbers in terms of disproportionate impact of coronavirus. This is infection rates. And in fact, the most disproportionately impacted community is the Pacific Islander community, which is relatively small in the state, but you can see at nearly 350 cases per thousand is just off the charts in terms of impact. The Hispanic community, much larger, but also extremely disproportionate, particularly, pardon me, in our rural communities. Next slide. As we've moved from spring to summer, we've also now seen a shift that's been well documented in terms of age of cases. On the left-hand side, we look at hospitalization rates, and you can see that they track closely to age. On the right-hand side, however, the numbers of infections, the case rate per 10,000, skews very, very young. 20 to 29-year-olds, 30 to 39-year-olds in particular, 40 to 49-year-olds. Now, when we see this figure, I think we're tempted to think of college kids in Florida partying in bars and things like that. And to be sure, there's an element of that, but we're also really talking about the workforce. And in this case, if you interface this number with the Latino numbers, what you're talking about is a workforce that's disproportionately in frontline or essential jobs, where they're in high density employment like food processing, or high exposure jobs like long-term care and those kinds of things. So there's a lot wrapped up in that statistic. Next slide, please. Now, this really, I think, just captures what I talked about a minute ago, but underlying conditions really are what are driving bad outcomes, particularly for Black and Pacific Islander Oregonians. And if you go back to that, the data on years of life lost and the underlying causes, they're really very, very similar in terms of hypertension, diabetes, obesity, and those kinds of things. Next slide. So we at the Health Authority need to operate differently. Our 10-year goal is to eliminate disparities. We can only succeed if we work in partnership, not only with healthcare providers, but with the community. Both providers and health policymakers are contending with historical distrust. The government role in perpetuating systemic racism in law enforcement, education, housing and economic policy, healthcare, legacy of medical experimentation, the legacy of lack of access and quality of care. Typhoid blankets given out to Native Americans is a fresh event in the collective memory of tribal communities, as an example. And of course, the Tuskegee experiment, syphilis experiments, again, a fresh event in terms of the willingness of Black Oregonians to trust healthcare providers. Let's go to the next slide. So there have been some specific equity challenges as we look at responding to COVID-19. I talked about restricted access to healthcare. Given the disproportionate impact of coronavirus on the Latino community, what's especially become a barrier is not only the generally lower rates of access to health insurance and thus healthcare, but also the citizenship status of people who are being impacted, skewing very heavily to people who don't have legal status in the country. I talked about the step that Oregon took about 5 years ago to make sure that we've got access to the Oregon Health Plan for all children, regardless of their status. We don't have a corresponding program for adults, and thus we have lots of adults who don't have a regular connection to healthcare. Another big problem that we've had is the ability to effectively isolate and quarantine. And this is really tied to the economic circumstances and that socioeconomic disparity that occurs, where you've got people who, again, don't have status, need to go to work each day to feed their family, don't have access to some of the same supports that that white or other Oregonians have to be able to pay them to stay home and effectively quarantine. And we've seen this play out in really, really high infection rates in places like Umatilla, Morrow, Malheur County, Marion County, as it's been very difficult to be able to overcome those economic imperatives. I've talked a lot about language and communications barriers, and then that fundamental distrust of government agencies. If you flip from the history of disease and interactions with medical professionals in the Native American and Black communities to current experiences of Latino Oregonians around government agencies, questions of immigration status, being picked up and deported, having access to any services be counted against them in proceeding through, gaining legal status. These things all build up to create a circumstance where their willingness to trust local public health or state public health is very, very low. Next slide, please. And really, when we think about our COVID-19 response, we think of a variety of dimensions to it, and we need to make sure each of those dimensions addresses equity. I won't talk about each of these, but data collection I do want to talk about, because we're going to be calling on you at some point in the next several months to begin providing information about race, ethnicity, language, and disability in different ways than you have previously as providers. This is based on legislation passed by, a bill passed by the legislature that begins to go into effect on October 1st and tries to do a much more comprehensive job of more accurately collecting this data than the standard census categories do. For instance, breaking Asian into more meaningful subgroups that have a much stronger connection to what the underlying challenges are based on that. I also want to touch on vaccination. We're going to have some big challenges, I think, when vaccines become available. I've heard it said, and I've been repeating a lot, vaccines don't prevent disease, vaccination prevents disease. And we're already in a state that has a high rate of vaccine hesitancy. Again, hearkening back to times of medical experimentation, we've got some barriers in front of us when we think about the fact that there are populations that already have a tenuous connection to healthcare, distrust of government sources, and yet need the vaccine more than other populations do, because that's where the most spread of disease is. It's a huge issue. Next slide, please. Part of what we've done to address this problem is think differently about how we engage with communities that have a history of racism, oppression, and disproportionate impact of disease, and this history of lack of trust. And so we've worked with now 170 or 180 community-based organizations to help us in our response to COVID-19, to be the front line, to be the face of the response, because they're in community, they're trusted partners, they're trusted voices, and we can work through them to be much more effective collectively as a system in dealing with this whole range of issues that we've talked about. They're organized all across the state and have really significant ties in their communities. We, in fact, have just awarded about $45 million in mini grants to a couple hundred of these organizations to do all those basic things I talked about in terms of food security, housing, other kinds of cash assistance, childcare, whatever it is people need to be able to, that exist as barriers, especially to effective quarantine and isolation, which is the number one tool we need to be able to gain control over the pandemic. Next slide. Those $45 million grants, we've tried to track to the basically the prevalence of coronavirus. The money is on the right-hand side. The prevalence is on the left-hand side. And so we've tried to break out of an ordinary mold. This was a fairly controversial investment the legislature made when it finally approved this. And it was because we didn't go through the ordinary process of do us a detailed proposal, line out exactly what's going to get spent where, and all those kinds of things that become structural barriers to the organization's best positioned to be able to provide this assistance. Next slide, please. And finally, we've tried to really change our organizational response and how we approach communication. Our first COVID-19 case was confirmed on February 28th. Since then, we focused on making sure that health information, guidance documents, and other materials are translated into multiple languages. Since the 28th of February, we've produced more than 5,600 documents. That's actually more documents than the CDC has produced in that period of time. Each of those documents, almost all of them, have been translated into 11 different languages. Translation is vitally important, but we also want to make sure the translations are timely, and our goal is to make sure we've got those 11 languages translated within 24 hours of putting out a document. We do Spanish language simulcast of our news conferences and Facebook Live events. Those have reached as many as 24,000 Spanish speakers at a time. We have our staff engage on Spanish language radio. We have a Spanish language Facebook page that's not just our regular Facebook page translated into Spanish, but it's it's natively created as a Spanish language site, and so it's got some differences. Next slide. We've also prepared specific response plans that are directed specifically at individual populations that are, as I've gone over before, those most directly impacted. Next slide. And so even though it's not going to be easy, this focus on health equity in the coronavirus response, and as we come out of the coronavirus response into our general work as an agency and as a health community, is the right thing to do. If we can eliminate health inequities, we improve health for everyone. A good example of this is how a curb cut in a sidewalk makes that sidewalk easier to navigate, not just for people with disabilities, but parents with strollers, seniors using walkers, workers pushing carts, and the list goes on and on. Now that we've got this 10-year goal, we're going to be developing 3 to 5 year plans for how to get there from here. Then we'll take those goals back out to tribes, historically underrepresented communities, and providers like you, and ask if we're on the right track. It means changing our policies and practices, and we're going to make a lot of mistakes along the way. And there are going to be a lot of voices that resist change. As you go out and try to talk directly to people without kind of beating around the bush about the effects of racism, about genocide, about slavery, people react viscerally to that and push back, and we're going to need to overcome that. Finally, I hope that you'll join in working to eliminate these health inequities. As I said earlier, if we can eliminate health inequities, we improve health for everyone. That's why we as a health authority were created. It's what we're here to do, and we look forward to working with you to do that. Thank you.
Thank you, Director Allen, for your presentation. We have a few minutes to go through some questions from the audience. I appreciate Director Allen being able to answer some of those questions during the chat, but I'm gonna go ahead and ask some of them, and we'll hopefully be able to get your response live here. All right. So the first one is, let's go with how has dependence on employee-sponsored health insurance influenced the distribution of COVID cases in Oregon?
Yeah, thanks. And I tried to answer this a little bit in the Q&A at a point where I was having a hard time figuring out how to work that part. But one of the challenges is the highest incidence of COVID has occurred in populations that are least likely to have health insurance. And this has had all sorts of ripple effects. So if I understand what the questioner is getting at, our dependence on employer-based health insurance in a system that doesn't require employer-based health insurance, across the entire workforce has created real barriers. We've also got challenges with the same most at-risk populations having citizenship status concerns, making it difficult for them to access coverage through other means. And so really it's the breakdown of connection to primary care that I think is one of the biggest barriers we face.
Thank you. Next question is, what have some federally qualified health centers done to reach out to patients of color, especially when an area is predominantly white and poor as well? The question asker comments that we are in Redding, California, and serve some 30,000 poor patients that are mostly white, but we still need to reach out better to our patients of color.
Yeah, I'm not sure I've got a good answer for that one based on my own experience working with our FQHCs in the most impacted populations. I can't think of areas that have a similar demographic to Redding that also have a really high incidence of COVID. So I don't know that I have a good example to be able to point to there.
Okay, thank you. And then next question is, how has OHA done outreach to primary care providers to help manage confirmed COVID-19 cases? Yeah,
so I'll answer that in a couple of ways. In terms of outreach to primary care providers, we have regular regular online provider webinars that have focused on whatever the most recent and topical issues are throughout the pandemic, to give people an opportunity to ask questions, hear from our experts, those kinds of things. And if we haven't already, I can make sure the association's got the information about how to log on to those and can circulate them to members. In terms of connecting primary care to cases, there are a couple of ways that we're working to do that. First, again, we got the basic barrier of we're often dealing with people who don't have a primary care provider or a connection to primary care. That's a challenge. Coordinated care organizations in Oregon are an important piece of that connectedness. And we've been working with CCOs and their provider networks to try to help deal with that. That has got the challenge that's related mainly to the Medicaid Oregon Health Plan. And again, much of the most impacted population isn't eligible for the Oregon Health Plan. And so we've got some layered problems that are a challenge, but I think those are probably the two main things I would point to.
Great, thank you. And then the next question is, how will the state of Oregon address the large inequities and disparities of our mental health system as it compares to our physical health systems? You talked a little bit about how east of the Cascades, there's really very little mental health kind of culturally appropriate. And I think the questioner is curious what we're doing about that.
Yeah, so it's interesting. In addition to what I put in the Q&A box, there's been sort of a revolution in telehealth as a result of the pandemic. And going into the pandemic, I think we had often pointed to telehealth as a promising way to be able to deal with some of these language and cultural barriers in remote parts of the state where it's really difficult to get a Spanish-speaking psychiatrist in a small remote community, but through telehealth we can get services from a Spanish-speaking psychiatrist to that remote community. What we found as telehealth rates have skyrocketed through the pandemic is that equity concerns get raised rather than answered, and it's really around access to technology, connectivity, those kinds of issues. And so I think one of the things we've learned coming out of this is we need to deal with both sets of issues. We've got to be able to expand the pool of providers to serve communities, and we've got investments in health education to do that, including expanding the use of peer supports and other community health workers as a way to build out that workforce. And then we also need to be able to figure out how to use telehealth, not just in terms of where it gets sent from, but how it gets received and is able to be accessed by a variety of communities.
Great, thank you. We have time for just one more question. I really appreciate all of the questions coming in, but this last one, there's been several comments in the chat from Dr. Gaudino, and I'm going to read one of his most recent questions, which is, while I applaud the investment to CBOs to address real on-the-ground issues and impacts for Oregon communities due to COVID, this is amazing, but again illustrates my point about how public health at the community level is ignored and underfunded. Local and tribal public health have the expertise and training to help communities implement evidence-based public health interventions. What is the role, if any, of local and tribal public health in these efforts at the community level?
Yeah, thanks. That's a great question, and I think you Doctor made the comment in the Q&A earlier. Oregon went into the pandemic with probably the 47th or 48th lowest funded public health system in the country, and it turns out that's not a good thing to go into a pandemic with. Local and tribal public health is critical. And that's why during the time I've been at OHA and over about the last 4 years, we've really been making a big push to increase funding of public health through public health modernization. So not only put more money in the system, but put more money in a system that's structured in a way that's different than the traditional, this disease gets this many dollars and that disease gets that many dollars kind of a structure. And we've had some pretty good success. It's also been challenging explaining what public health modernization is to policymakers. And I think now they've got a much better idea of that investment that you make in local public health to be able to case investigate and contact trace tuberculosis or chlamydia or something like that is the same infrastructure and skill set that you then need to be able to ramp up to be able to deal with coronavirus. And so in all of these cases where we've made investments in these 170 or 180 community-based organizations, we require an MOU between the organization and local or tribal public health working in the same area, so that the nature of the relationship may vary widely across 33 different public health authorities around the state, but that there is a structure to that relationship and a set of understandings and accountabilities back and forth.
Great, thank you. I know we have a wonderful presentation coming up on public health and the importance of engaging, so hopefully we can have some more good conversation about this. But we do have to wrap up. Director Allen, thank you very much for joining us. It looks like several more questions have popped up in the Q&A. If you're able, we would love for you to do your best to answer some of those in the chat after we move on. But thank you very much for joining us today.
Thanks for having me, and I'll dive back into the questions and do my best.
Great, thanks.
Thanks.
Before we move on to the next presentation, I would like to extend to the partners group a brief opportunity to address the audience.
To our partners at the Oregon Medical Association, we want to say thank you. Thank you for working hard every day to keep our families, friends, coworkers, and communities safe. We know that your work hasn't been easy, and we know that it's far from over. For over 25 years, the Partners Group has been serving the needs of the House of Medicine. As your long-term, trusted partner, the Partners Group is here to help shoulder some of the burdens that the COVID-19 crisis creates. We can help make sure that throughout this pandemic, your medical malpractice programs, employee benefit plans, and retirement programs are well managed and delivering on the promises that you make to your employees. We can also ensure that your personal insurance, financial plans, and investments stay on track during a chaotic, uncertain time. Let us take care of the details for you so you can get back to what's most important, caring for Oregonians. Thank you.
It is now my great honor to introduce our keynote address, Architects of the Future, presented by former Governor John Kitzhaber. Governor Kitzhaber is an emergency medicine physician who began his medical career in Roseburg and was later elected to the Oregon House of Representatives and Senate. During Governor Kitzhaber's tenure as Senate President, he authored the groundbreaking Oregon Health Plan, which sought to prioritize health services based on social values and clinical effectiveness. In 1995, Kitzhaber was elected as Oregon's governor and served in that role until 2003. He was elected again in 2011 and served until 2015. During Governor Kitzhaber's third term as governor, he was the chief architect of Oregon's coordinated care organizations, the first statewide effort in the country to meet the triple aim: better health, better quality, lower cost, with a focus on community and population health. During his career in medicine and public service, Governor Kitzhaber has transformed the healthcare landscape and increased access for all Oregonians. We are proud to count Governor Kitzhaber as a member of the OMA family.
Good morning, and thank you for inviting me to speak today. I can only say that I wish I could actually see you. I'm sitting here by myself in an office over at the OMA, and while I certainly understand the need for virtual conferences at this point in time, I do miss the audience. I miss looking at the people that I'm speaking to. I miss the human touch. So let's pledge to each other this morning that notwithstanding the important role that telemedicine is going to play in our future, that we won't allow the human touch to be extinguished from the practice of medicine. I want to start today with a statement and see if you can figure out when it was written. Here's the statement. The fruits of the toil of millions are boldly stolen to build up colossal fortunes for a few, unprecedented in the history of mankind. Now that could have been written in 2020, because today, three men, Jeff Bezos, Bill Gates, and Warren Buffett, have more wealth than the poorest 160 million Americans, or about half the population of the country. And today, income inequality is greater than it was in 1929, when 10% of the population possessed 84% of the wealth. Actually, the statement was written in 1882 as part of the platform of the newly founded Populist Party. And I'm not sharing it with you to make a political statement, but rather to illustrate two things. First, how little progress we've made in the past 138 years in terms of social justice and equal opportunity. And secondly, the fact that the relentlessly increasing cost of healthcare has become a major contributing factor to the inequities and disparities that exist today in our society. Over the past 6 months, we've seen the human consequences of our failure to embrace a policy of universal coverage. We've also witnessed the difficulty that non-medical essential workers have had obtaining adequate health protections, which has resulted in many cases in higher infection rates. These are people who don't have the luxury of working from home. They hold low-wage positions, often with little sick leave and little health insurance. They work in grocery stores and warehouses, farms and factories, restaurants, hotels, and retail establishments. And we've all seen Black Americans dying from COVID in dramatically disproportionate numbers, these deaths being attributable to structural inequities in our society that make Black people and Indigenous people and other communities of color more likely to have diabetes and heart disease and hypertension, and inadequate housing, and fewer economic opportunities. Now, the pandemic did not create these inequities, but it certainly has exposed them. These are the very conditions of injustice that the Populist Party was calling out 138 years ago, and they've been with us since before the nation's founding, churning just below the surface and only indirectly visible when we examine the disparities in educational and health outcomes for chronically under-resourced and often racially or ethnically segregated communities. Now these disparities are laid bare, and the pent-up frustration is boiling over into the streets. Indeed, the protests of the past 3 months around Oregon, and particularly in Portland, are set against the backdrop of perhaps the most difficult set of challenges that our state's ever faced. Not only do we have a public health crisis, we have record high unemployment, and the legislation to extend unemployment supplemental benefits is stalled in Congress, leaving tens of thousands of our fellow citizens with a shrinking capacity to be able to pay for food and shelter. The inability to reopen the schools this fall has added stress to children and to parents and to teachers, and we have a huge projected budget deficit. And all of these things are converging in the charged atmosphere of a very polarized and divisive election cycle. And now we have the fires. That's a lot. And I think we all recognize that we are at a dangerous and very uncertain point in the history of our nation and of our state. But I also think that our future will be largely determined by the attitude we take in how we approach these multiple challenges. You know, over the past few months, past few weeks when I've been overwhelmed, I've recalled a passage from A.A. Milne's Winnie the Pooh that I used to read to my son when he was very young. And in this passage, Pooh and Piglet are walking through a forest, and Piglet looks up apprehensively and says to Pooh, "Pooh, what if one of those trees falls on us?" Pooh looks at him and says, "Well, what if it doesn't," right? So the point is, how are we going to respond to this? And I think there's two choices. We can respond by clinging to the past and by defining ourselves as champions of a status quo that is increasingly unsustainable fiscally and indefensible morally, or we can choose to be the proud, courageous architects of a new future. And knowing you as I do, I'm pretty sure what the answer is going to be. 10 years ago, we faced a similar set of circumstances, and we rose to meet the challenge. In 2011, Oregon was in the depths of the Great Recession with high unemployment and a polarized electorate, and a divided legislature that was facing a $3 billion revenue shortfall, $1.2 billion of which was in the Medicaid budget. Now, one path was to cling to the status quo and drop tens of thousands of Oregonians from coverage or cut provider reimbursement rates by up to 40%. The other path was to redesign the delivery model to get more value for each dollar we were spending. And we came together as an industry and as a state, and we chose that second path. And the result, of course, was our coordinated care organizations. While not perfect, they did help save the state hundreds of millions of dollars during the Great Recession and expand coverage and successfully navigate the politics of managing a large budget deficit without tearing ourselves apart as a state or as a community, which is very, very important. Now, a decade later, we find ourselves in a similar set of circumstances, and again, we need a strategic plan. What's different about today than 2011 is that healthcare has become the largest all funds expenditure in the state budget and the second largest general fund expenditure, which means that the state budget, which is facing a $4 billion revenue shortfall, can't be brought into balance without significantly reducing the cost of healthcare. And without a well-defined strategy, the healthcare budget could become just another moving part in a balancing exercise, budget balancing exercise that's disconnected from any long-term responsible policy framework. And the 2021 session could disintegrate into a political fight in an election year between stakeholders all trying to get their share of a shrinking pie. We have the opportunity to avoid that outcome, which wouldn't be good for you or for the healthcare system, or most importantly, for the citizens of the state of Oregon. We have the opportunity to lead by developing that strategic plan and building on the steps we took in 2011 to accelerate the transition to goals that we already recognize are necessary, and in particular, the move to value-based payment. In short, I believe we have a once-in-a-generation opportunity to better align our system with caring and with compassion and with the goal of improving health of our state and the people who live here. No one is more qualified to lead that effort than people who have dedicated their lives to the healthcare profession. If I could have the next slide, please. Over the next few years, and particularly over the next 10 months, if I could have the next slide, please. Over the next few years, and particularly over the next 10 months, we're going to face three interrelated challenges: to reduce the total cost of care without sacrificing access or value, to maintain the integrity of the delivery system in a resource-constrained environment, and to effectively address the health disparities that continue to exist in our society and in our healthcare system. So over the next few minutes, what I'd like to do is talk to you and walk you through how COVID-19 has fundamentally changed the political and fiscal landscape in which the healthcare system operates. And that discussion hopefully will help inform the key elements that we need in our strategic plan to meet this challenge. So among the many impacts that COVID-19 has had on Oregon, three in particular stand out. I have the next slide, please. The first impact is the impact that the COVID-19 pandemic and the steps for social distancing have had on utilization of healthcare services, which, as you know, over the past 6 months have dropped by as much as 40% from historic patterns, creating a fiscal crisis, particularly for those portions of the system that are most heavily dependent on fee-for-service. That has exposed in a very real way the irrationality and I think the vulnerability of a payment system that is focused more on volume than on value. And that fact should also help inform our strategic plan. We're going to have the next slide, please. Perhaps more importantly, however, is the impact that the pandemic has had by exposing the extent to which our healthcare system and its fiscal viability depend on public resources and on public debt. And that's kind of an abstract concept, but it's very, very important. So let's look at it a little closer. Consider the fact that healthcare is the only economic sector that produces goods and services that none of its customers can afford, right? So the only way this works economically is because the cost of medical care for individuals is heavily subsidized with public resources, either directly through public programs like Medicare and Medicaid or CHIP, or indirectly through the tax exclusion for employer-sponsored coverage or the subsidies you get if you buy a policy through the ACA exchange. Next slide, please. So if you look at this subsidy map, you can see that over 90% of Americans currently get some form of public subsidy to help pay for the cost of their health care. The subsidy for Medicaid is federal and state. If you get a policy through the ACA market, your subsidy comes from the federal government. If you have workplace-based coverage, the subsidy comes from your employer and from the federal government. And of course, Medicare is primarily a federally subsidized program. The point is that this system only works because it's heavily propped up with public resources. We can also see from the subsidy map that the only people who are not entitled to a subsidy are the 32 million uninsured Americans. If you think about it, these people are all working because they're making too much to be eligible for Medicaid, but can't afford the cost of a private policy. So while not entitled to a public subsidy themselves, through their taxes, they're underwriting the subsidies for everyone else. And this is clearly one of the most egregious inequities in the healthcare debate, and it drives much of the debate from a political standpoint. But not only is the economic viability of our system dependent on public resources, it's increasingly dependent on public debt. And that's because Congress is borrowing ever more money to pay for current programs and services, including healthcare. That's reflected in the growing national debt. Now, the national debt represents the amount of money that's borrowed to cover the difference between what Congress is spending and the taxes available to pay for it. Since healthcare today accounts for 28% of the federal budget not spent on interest and is expected to go to 33% by 2028, healthcare has become a major driver of the national debt. Next slide, please. That means that as the cost of healthcare continues to increase and as the population ages, the economic viability of our healthcare system will increasingly depend on borrowing money and on the capacity of the federal government to absorb more debt. If the capacity to borrow is somehow constrained, then the financial underpinnings of the whole system begin to unravel. And as we'll discuss in a moment, COVID-19 has created exactly that kind of constraint on borrowing, thus bringing a healthcare financing crisis, which was on our horizon, right to our doorstep. Next slide. Finally, since the cost of healthcare is claiming an ever-growing share of public budgets, it's undermining our ability to invest in other things that we know have a far greater impact on the health of the population. That means that as the cost of healthcare continues to increase, we're going to be reducing the amount of money that we can invest in the social determinants of health. And that's things like, of course, healthy pregnancies, nutrition, housing, stable families, safe communities, education, and economic opportunity. And as COVID-19 has graphically, and I would say tragically demonstrated, the burden of our failure to make these social investments has fallen disproportionately on the poor, and particularly on Black people and Indigenous people and communities of color. So now let's take a moment with that scan of the landscape and look at the federal response to this situation and then try to bring it back here to Oregon. Next slide, please. The crucible that we find ourselves in today is the result of the intersection between public financing and public debt and the economic downturn caused by the pandemic. In order to prevent a complete collapse of the economy, there's been this massive federal intervention, both from Congress and the Federal Reserve, to keep credit flowing and to provide loan guarantees and direct payments to businesses and to individuals. There's another relief package in the works, but it appears to be hopelessly stalled in the United States Congress. In any event, this massive federal intervention, even to date, is going to leave us with an unprecedented budget deficit and a national debt that's approaching $28 trillion, which is going to leave very little capacity to absorb what is a projected 60% increase in the size of the healthcare economy by 2028, from 3.7 trillion to 6.2 trillion, especially since prices are projected to account for about 43% of that spending growth. So we need to come to terms with the fact that we're entering an era of profoundly constrained public resources, and it will be particularly difficult, perhaps impossible, to afford the projected rate of medical inflation here in Oregon and across the nation, particularly given the economic losses that employers and individuals have experienced, and of course the massive public debt that's been accumulated just to keep the current system from falling apart. Here in Oregon, if I could have the next slide, please. The legislature, as I mentioned, is facing a $48 billion budget deficit for the 21-23 biennium that begins next July, just 10 months from now. While the state does have about $2 billion in reserves, these are going to have to go to address problems across the entire general fund, not just in healthcare. And it is unclear if or when additional federal funding is going to become available. In any event, a federal bailout is not something we can count on, and I would suggest that waiting for outside help is not a strategy, it's a recipe for disaster. That's why a strategic plan is so critical. So we need to start with a clear idea of where we want our healthcare system to be in 5 years so that we can ensure that the individual steps taken by the legislature next year are not simply focused on eliminating a revenue shortfall for a 2-year period, but actually put our healthcare system on a sustainable footing for the 2023-25 biennium and beyond. Now, certainly there's a lot of risk in the months and years ahead, no question about it. But I would argue that there's a far greater risk in clinging to the belief that we can return to the old paradigm a few months from now. Because even when the economy recovers, it's not going to begin to mitigate either the national debt or the deep fiscal losses suffered by the state of Oregon. So the fundamental reality is that we are going to have fewer resources, not more resources in the months and years ahead than we had in the past. I think the central question for you to begin to consider is how would we manage to a total cost of care level that's maybe 15 to 20% lower than what we had in 2019. Next slide, please. So I'd like to use the remainder of my time to offer one way that we can approach this, that we can manage to that lower total cost of care level. And let me preface this by saying that the devil is always in the details. So what I'm going to present to you is just one way and a broad outline of how we could address 3 key objectives: to maintain the integrity of the delivery system, to expand coverage, certainly not reduce coverage, and to reduce the total cost of care. I think those are the 3 key objectives. Now, as I said, there's other ways to approach this, but I think you need to keep in mind that the general fund expenditures for healthcare will be severely constrained in the next biennium. And the decisions on what that looks like are going to be made by legislators starting a few months from now. So I believe it's in your best interest, and I believe it's in the best interest of the state of Oregon, for you to provide leadership and offer a strategic plan, one that can be embraced by the rest of the healthcare sector, to guide the inevitable changes that lie ahead. So the outline that I present here is going to be focused primarily on those populations where public dollars are at risk, because as we discussed earlier, healthcare competes directly with these other important social inputs. These populations include Medicaid and the healthcare programs that provide coverage to public employees, the Public Employees Benefit Board, or PEB, and the Oregon Educators Benefit Board, or OEB. Now, I've also included the ACA individual market in this, and let me explain why. As you know, the ACA subsidized market was created by the Affordable Care Act to help low-income Americans without employer-sponsored coverage. And indeed, this is probably the only option for Oregonians who earn more than 138% of the federal poverty level, so they're not eligible for Medicaid, but lack employer-sponsored coverage and find it difficult to find coverage in the individual market. So although this subsidized market is paid for, the subsidies in the market are paid for by the federal government, not the state government, so it doesn't impact our $4 billion budget deficit. Keeping that market affordable is a key element of moving Oregon towards universal coverage, which is a point I'll come back to in a moment. Next slide, please. So in making the case for this approach, I would make 3 points. First, as we discussed earlier, healthcare has become the single largest all funds expenditure in the general fund, and the second largest general fund expenditure, second only to education. And this growing liability on the state general fund is competing directly with resources that are needed for housing and other social services that also contribute to health, not to mention propping up our educational system. Secondly, healthcare has also become a growing part of the total compensation package for public employees, which means that in the collective bargaining process, wages are pitted directly against healthcare benefits. Also, for public employees, the general funds that go to support their healthcare compete also with wages and with other investments like increasing nursing staff ratios and decreasing class size, and of course, investing in the social determinants of health. Traditionally, in collective bargaining, the goal of the bargaining unit is to reduce to the greatest extent possible the out-of-pocket costs to the union members. The problem with focusing only on that aspect of the total compensation package without challenging the cost structure or the quality or the efficiency of the care that's being delivered simply drives down wage growth and puts additional pressure on the general fund. And finally, I want to mention that as we discussed earlier, the fee-for-service payment system in a real sense failed the healthcare system during this pandemic. and expose the vulnerability of a business model that's based on volume rather on value. And although for years we've paid lip service to this notion of moving from volume to value, the pace has been glacially slow. Now's the opportunity to speed it up. I think that the current projected revenue shortfall creates an urgency, if not a necessity, in accelerating that movement from fee-for-service to capitated models, probably incorporated in global budgets indexed to a sustainable growth rate, and risk-based contracts with provider networks. Over the past 5 years, we've demonstrated the viability of that through our CCO model, over which 25% of Oregonians are now in that model, and it contains exactly those elements that we need to move into the commercial market. So could I have the next slide, please? There are two central elements to this proposal I'm laying out today. One of them is to ensure maximum enrollment in existing programs, and the second is, of course, to reduce the total cost of care. Next slide, please. We know that if only 80% of those who lack health insurance coverage in Oregon made use of coverage for which they are currently eligible, that is the Oregon Health Plan or the ACA individual market, the number of Oregonians who are uninsured would drop from around 280,000 to 34,000. That's a drop in the uninsurance rate from 6.2% down to about 0.08%. The top two reasons people give for not being covered is they're concerned about high out-of-pocket expenses or not knowing that they're eligible. Well, we know that there are no premiums and no deductibles for the health plan, and those with incomes between 138% and 250% of the federal poverty level are eligible not only for premium subsidies, but also for cost-sharing reduction subsidies in the ACA market. The problem is that given the relentless increase in the total cost of care, even the ACA market is becoming unaffordable for a growing number of people. So the general fund would certainly be strained if everybody who is currently eligible for Medicaid were to suddenly enroll. In other words, even if we can ensure that everyone is enrolled in programs for which they are currently eligible, the steady increase in the total cost of care will undermine our ability to maintain that coverage over time, not just in Medicaid, but in the commercial market as well. So that means our top priority must be to address the total cost of care and to ensure that we're getting value for the public subsidies that are supporting the healthcare system. That involves taking steps that impact both Medicaid and the commercial market. So let's walk through those. Next slide, please. First, I think we need to consider capitating hospitals for the Oregon Health Plan. Bay Area Hospital in Coos Bay and St. Charles in Bend are already capitated. Pennsylvania is moving in this direction for its rural hospitals. And as we discussed earlier, the economic fallout from COVID-19 has demonstrated the perils of clinging to a pure fee-for-service system. Second, I think we should reduce to some extent the 3.4% per member per year growth rate. Even a small reduction in the trend yields significant savings long term. Third, we need to remove the excess administrative burden that has been added to the CCOs as a part of CCO 2.0. I would cite as an example the new risk-based capital requirements for CCOs. Next slide. We also need to seek additional Section 1115 waivers for two purposes. One, oops, I seem to have lost my place here. Yes, here we are. The waivers would be for two purposes. One, I think it's really important that we move CCOs back to a true global budget, which was, of course, the original intent. It's important to move away from a claims-based medical loss ratio to a health loss ratio, where CCOs are not penalized in the rate-setting process for investing in the social determinants of health, for which there may be no claims or no billing codes. We also need to try to get additional federal resources into the state during this next waiver period, which we did back in 2011, if you recall. And I would suggest trying to get additional federal resources for CCOs that will spend up to 3% of their budget on community-based social determinants of health, which will try to directly address health equity issues. And secondly, enhance payment to providers who can demonstrate that they can address the culturally and linguistically appropriate services needed in their communities, particularly around behavioral health. Next slide, please. We also need to establish much clearer access and outcome requirements for both mental health and social and substance use disorder. As you know, the pandemic has created this huge growing need for effective behavioral health services. Let me give you just a couple of statistics. Today, 1/3 of Americans are reporting stress and anxiety levels that are difficult to cope with. And that, of course, goes hand in hand with the difficult economic circumstances that they're facing. 59% of primary school teachers and 49% of secondary school teachers are experiencing high stress and anxiety. Furthermore, we know there's an increase in substance use disorder, which is probably the biggest cost driver for coordinated care organizations. So significant investments in this area can also yield cost savings downstream. Finally, I think we need to better coordinate the state purchasing power, particularly to negotiate prices for high-cost specialty drugs for which there are no generics. State-financed populations that could participate in this purchasing pool could be Medicaid, PEB and OEB, the Department of Corrections, and the State Accident Insurance Fund. And I also think we should make better use of the Northwest Prescription Drug Consortium. Now, in addition to these steps that we are taking in the Medicaid program, we also have to take actions in the commercial market, which gets us right to the heart of the matter. Extending the CCO model into the commercial market was always part of the original vision of our transformation 10 years ago, but we just haven't gotten it done. And that's because it's a heavy lift. It gets right to what keeps us ticking. It gets to reimbursement levels, it gets to payment levels. It is a heavy lift, but now is the time that we need to do it. Next slide, please. To me, this involves moving both the ACA individual market and PEB and OEB into some sort, away from fee-for-service and into a risk-sharing arrangement, probably within a global budget, that's based on a uniform fee schedule that could be negotiated, moderately well-managed utilization assumptions, and a value-based benefit design. Next slide. Now, for this to work, we've got to have a new equitable risk-sharing arrangement between payers and providers to ensure that they share equitably in both upside and downside risk. If we're going to have to reduce the healthcare spend in this state by 15%, there's not enough margin to go around if we all cling to our own silos. So we've got to realign incentives between payers and providers, with payers assuming primary responsibility for true insurance risk, that would be extraordinarily high-cost patients or out-of-area care, with providers assuming primary responsibility for managing utilization. We also need to make sure that risk is not simply held at the plan level and cost managed by denials or prior authorization, but that the risk actually flows downstream to the providers with appropriate alignment of incentives to manage both quality and cost. Now, what I've laid out to you is only one way that we can approach this difficult challenge, but it does incorporate the three objectives that I think are essential: reducing the total cost of care without compromising access or value, maintaining the integrity of the delivery system in a resource-constrained environment, and effectively addressing health disparities. These are the goals. These are the waypoints that will help us navigate the difficult waters ahead. Now, some of you may disagree with some or all of what I put on the table here today. Fine. If so, you need to come up with something else, because if we are unwilling to let go of the shore, the surf will pound us to pieces. I believe that the only way to approach this challenge is to embrace the change, not to resist it, and in fact, to lead that change. So my message to you today is simply this. I believe that you must assume a leadership role to develop a strategic plan to present to the Oregon Legislative Assembly, and be willing to sit down with other key stakeholders, including hospitals and other providers and consumers and payers, in a common effort to get to yes and help guide this state and its healthcare system through the most difficult economic and social moment in its history. Last slide, please. Somewhere in America, during this difficult time, a state needs to demonstrate that we can weather this storm without losing our sense of community, without losing our commitment to one another, and emerge stronger and more unified than when we began. Let's make that state Oregon, and let's make this proud organization the chief architect of a brighter and better, fair, and more sustainable future. Thank you.
Thank you, Governor Kitzhaber, for your perspective and your clear plans in an approach to tackle some of these problems. I really love how you say we won't allow the human touch to be taken away, especially during the pandemic when social isolation has become such a real thing. So thank you very much for your comments. We do have several questions coming in, and we have a few minutes to answer those. So I'm just going to jump right in with our first one.
You're good.
Oregon currently spending 20% of healthcare dollars on administration, not healthcare. This is double the administrative costs of other industrialized nations. How can Oregon spend less on administration and more on healthcare?
Well, I think, basically changing the payment model from fee-for-service to a global budget, a capitation, where providers are operating within the context of a fixed amount of money, and where providers are managing that utilization, removes a lot of the necessity for, actually, I would say, the entire billing system. And if you think about it, we've got this huge industry of diagnoses and treatments, and the amount we spend on billing and collection is just enormous. So I think that if, in fact, you move to capitation and some kind of global budget, I think you could put a limit on the administrative cost. I'm sure we can drive that down, but the real cost savings are not going to be in administration. They're going to be in providing better care, the right care at the right time at a lower cost. And we've demonstrated with the CCOs over the first 5-year waiver period, we saved about $1.1 billion in total funds. And so I think we know where we need to go. The question is, how do we make that transition?
Thank you. Another question about cost. The biggest increase in Medicaid costs are related to pharmacy costs. How do you propose lowering the 3.4% target if drug costs increase at a much higher rate?
Well, again, as I mentioned, I do think that we're making a mistake not to pool our purchasing power. If you add up the covered lives we have in Medicaid and PEB and OEB and other state programs, there's a lot of juice there to negotiate, particularly high-cost specialty drugs for which there is not a generic. I would also think that having some conversations about aligning Medicaid purchasing with Washington and California would be also productive. And, should Senator Wyden become the chair of the Senate Finance Committee after the election, we should go after that prohibition that was put into Medicare Part D that prevents the federal government from using the volume of Medicare to negotiate drug prices. So I think there's a state and regional approach. There's also a federal component to this.
Great. So shifting gears a little bit to a question that's more near and dear to my heart as someone who practices narrative medicine and teaches the importance of stories. We have a question as we move, as you mentioned, towards quality of care and not quantity, especially using Black maternal mortality rates as just one profound example. It seems to me that one key element of the solution must be time to listen to patients so that their concerns, symptoms, and needs are actually heard by clinicians. How can we support each other to make time and slow down as clinicians to take better care of our patients? And are there any good examples of which you are aware in the setting of all of this cost containment and timing issues that we have as physicians and physician assistants and nurse practitioners here in Oregon?
Well, I think this is a question that goes far beyond healthcare. I mean, I believe that if we really want to get at the root causes of institutional racism and deal with the disparities in our society, most of them have their roots before people actually get into the healthcare system. And it's this profound lack of investment in families and children and communities and neighborhoods, which leads, I think, to the huge disparities that come downstream. And, I think this is going to require the seeding of resources and power, probably from healthcare and education, which are the two biggest components of our general fund, and into social services. And a key part of that is making sure that the people who are impacted by those services, be that healthcare or education or early learning, have a central and meaningful role in designing the way those systems are put together. In many cases, I think we come in and say, well, here's how we see the problem, and we're gonna address it this way. We need to listen and engage and cede power and influence to those individuals in order to ensure that they have some ownership in how those services are delivered, because they actually know best. We don't do that very well as a society, not just in healthcare, but I think across the board. And I think that needs to be a sort of an integral part of this transition in healthcare and in redesigning the educational system and other services across the board here in our state and in our country.
Thank you. Another question came in. Thank you for your inspiring remarks. As physicians and PAs have engaged and provided leadership and reform over the years, supporting policy that helps all citizens, payers have systematically taken advantage to decrease reimbursement while increasing their profits, and leading to reduced access to many essential services and loss of trust. How do we engage payers in these goals in a way that does not significantly disadvantage providers?
Well, I do think I mentioned this in my remarks. We have to develop a fundamentally different risk relationship between payers and providers. We have to realign the incentives between payer and providers. So we're going to continue to do exactly what the person who asked that question suggested. And we've been having some very productive conversations with some of the major payers in Oregon: Pacific Source, MODA, Providence, Kaiser Permanente. Just taking those, you have probably 80 or 85% of the market right there. And I think there's a willingness to sit down, particularly with this recognition of the constraints that are coming on the healthcare system, to renegotiate, to redefine that risk relationship. And, you can do those things in Oregon. We all know who the CEOs of those organizations are. This isn't California or New Jersey. And so I do think as a central part of this, we need to convene those stakeholders, the payers, the hospitals, the physicians, and have that conversation. And I'm very optimistic that if we approach this with the idea of creating a sustainable healthcare system for all the parties, but most importantly for the individuals who are receiving those services, I think we can get there.
So another question then, how do you think a capitation model would work for patients with palliative concerns, specifically those who are not necessarily ready for hospice, but are not expected to recover from their diagnoses and may live for many years? So how does patient autonomy fit into this when they choose not to follow the plan of care? Kind of going back to your comments about really having the patient be a part of that decision-making team.
Well, I think that I'm not sure it's so much a capitation issue as it is an acknowledgement of the importance of that aspect. My mother, who died a number of years ago, was living at home, and we were able to actually provide her what she needed, which wasn't medical care. It was the activities of daily living, cleaning the house, taking her to the bathroom, right? And at the time, she didn't need hospice care, right? She needed basically emotional and domestic support. And that wasn't paid for at the time. And if we were to actually reimburse a PA or a nurse or a physician to actually have this conversation with people, not when they're on their death's door, but when they're coming in the front end of the healthcare system about how do you want your end of life to look like? Who do you want to be there? What's important to you? Where do you want to be? And have that conversation early, because this is not a medical issue. This is when you've passed the point. There's a difference between cure and care. And what you're talking about is the point where it's about care and compassion and emotional support. And that needs to be acknowledged as a part of the system and legitimized. And we need to anticipate that as a payment aspect of the capitation rate. And the fact is, almost no one wants to die in an acute care hospital, but the system drives them in that direction. So we're not talking about telling someone they can't go to the hospital. We're giving them a choice for an end-of-life venue that makes sense to them, which, by the way, saves a whole boatload of money in the long term.
Yeah, I think that's a great segue into another question, which really goes back to a question that we asked Director Allen about public health, and that public health funding often is really able to fill the gaps of clinical care. And what do you think the role of public health and tribal health is in these efforts at a community level? And how can we as physicians and physician assistants and other providers really capitalize on the relationships with our public health colleagues?
Well, I think public health is actually the cornerstone of health, right? I mean, what I did in the emergency room is I was treating after the fact. I mean, people showed up there because in many cases they showed up because of unmet social problems. We take care of their medical problems and then send them back to exactly the same environment. So I think you have two issues here. You have the traditional public health issue, which is really, I think the pandemic in a way was a blessing in the sense that it showed us that we have such a fragile, in some cases non-existent public health infrastructure, or at least there's a lot of gaps in it. And that's one lesson we need to learn. It's about resources, but I think it's also about engaging the public health in the same conversation we talked about earlier. That is the populations that we're trying to support from a public health standpoint need to be really engaged in what that looks like. So public health, there's a huge opportunity here to really integrate public health as a foundational piece of our medical care system, of our healthcare system, because that's what creates the trajectory, the positive trajectory, along with those social investments we discussed, that reduces the input into the medical care system, right? So it reduces costs long term, but it restores the caring. It restores the caring to the healthcare system. So we have a huge opportunity here. I mean, the system's been blown up, the pieces are up in the air, we can knit them together in another way. But as I said earlier, we need a strategic plan to do that. And I think you folks are in a position to lay that out and bring it to the legislature next year.
Great. And I think we have time for maybe one or two more questions. You know, one thing that's coming through in some of the questions here is just the concern about provider burnout. And, you know, in the previous talk, we looked at the triple aim, and I'm just curious about your thoughts on the quadruple aim, really adding in that healthcare professional well-being and sense of meaning. And the question that's come in is really, what do you see the change from fee for service into these different models of healthcare? How do you see that impacting just the providers' general mental health and well-being and sense of fulfillment in their careers?
Well, I mean, I do think we need to have good, adequate reimbursement. We need to create obviously incentives. That means upside risk for managing patients well. But I think if you are on a capitated system where you have your resources on the table, you know what they are, it reduces the need for the doorknob visit, right? I mean, you just have to see people as a mill in order to pay the bills. So I think that's very important, and that's why it's important to have that conversation about what the assumed fee schedule is going to be when you're developing the capitation rate. What's going to be included in that, right? And when you actually seed risk downstream to providers, you need to create align the incentives so that if you are really efficient in managing a patient population and they don't come to visit you on a regular basis because they're well, that you need some benefit from that. I do want to add, though, I also think that we need to fundamentally change, and this is not a state issue, it's a federal issue, the subsidies for medical education. And I do think the subsidies need to be significantly increased for those specialties that we know we're going to need if we're moving to a population health system. That is primary care. To create a system where you're forced to go into a higher paying specialty because you're worried about student debt is not aligned with what we're trying to do here. So medical education has a key component, I think, as part of the solution.
Thank you. I really appreciate you addressing that as someone who works closely with medical students and really see that kind of tremendous burden on them going into different healthcare specialties and fields. So that's all the questions that we have time for today, but I did want to give you an opportunity to make any last additional comments before we have to say goodbye.
Well, you know, I'm sitting in the seat of my car here.
I see.
My lovely studio. To me, it's just bizarre I guess it's a great technology, but I sure miss interacting with people, and hopefully we'll get to do that soon. You know, this organization is really remarkable. When we did the Oregon Health Plan back in 1989, it was the OMA that basically drove that forward. And we were accused of rationing. We were being beaten up by everyone around the nation. And it was this organization that stepped up and said, no, there's a better way to do it, and we want to be in the forefront. You were there when we created the coordinated care organizations. And I would say this moment in time is even more crucial, and we can change the vector even more significantly over the next year. And I think this is designed for you. This is our time. This is your time. So I hope you really take this seriously. I know you will. And I'll do anything I can to help support you. I'm very excited about the contribution, the great contribution you'll be making here over the next year or two. Healthcare and health in Oregon.
Great. Thank you very much for taking time to be with us today. And enjoy the rest of your weekend.
Thanks very much.
All right. Wish we had more time for questions, but it is time to close out the session. I'd like to bring back our CEO of the Oregon Medical Association, Bryan Boehringer.
Thanks, Dr. Lahti, and big thanks to Governor Kitzhaber. Always learn so much when we listen to you. I want to thank everyone again for taking time out of their weekend to attend today. I hope everyone is finding value in the program so far. I know we have a lot of OMA members watching today, but I also know there are some of you out there that are eligible for membership but haven't yet joined. We would like to change that. Normally, I would tell you that the OMA is your advocate on the ground in Salem, the courts, and in Washington, D.C., and that the OMA is the primary organization that policymakers look to for information on their decisions that impact our members and their patients. But these are not normal times. We are still very much in the middle of a public health crisis where all healthcare providers are on the front lines providing care and are on the front lines of helping everyone understand what public health measures are necessary for us to get past this pandemic. Being a doctor or a PA has always been very important, but with everything that's going on now in our world, your work and your voice has never been more critical. I know from my many phone calls with you that the pandemic has disrupted clinics, health systems, and clinicians financially. And because these groups fund our mission, the OMA has been financially impacted as well. Nonetheless, we will continue to crank out daily resources for you, your practices, and your patients to help guide you through the impacts of COVID-19. We have been focused on making sure there is adequate PPE for the front lines and for community clinics, restarting non-urgent and emergent procedures. We are pushing for increased testing capacity, reliability, and turnaround time. We are advocating for aggressive public health messaging to help the public understand how to control the spread. We are also working for permanent telehealth payment parity and flexibility. We have worked with the governor and OHA to develop and communicate COVID-19 guidance and best practices. We are pushing for liability protection for providers that have to deviate from the standard of care to follow an executive order or department guidance. And finally, we are advocating for additional financial assistance and reductions of administrative burdens for practices. We must protect the healthcare safety net from financial ruin in order to serve patients now and after the pandemic. Your membership supports these efforts, and your membership makes it possible for us to put on this great program. If you are not an OMA member, I would ask you to join your fellow physician assistants, medical and PA students, and help us build an even stronger organization to advocate on your behalf. OMA staff will provide a link in the chat where you can get yourself or your clinic signed up. With that, I will turn it back over to Dr. Lahti. Thank you.
Thank you, Bryan. What a great start to our conference. This is exciting, but I bet people might want to take a little break and stretch your legs. So at this time, let's take a break. We will reconvene at 9:55. So please return at 9:55 so you won't miss out on our next presentation. We have some amazing speakers coming up, so I really encourage you to stay, especially those of you interested in public health, partnering, the racial inequity, and just the public health issues of racism. We've got some great speakers lined up for after the break. So please return at 9:55. Thank you.
CNA's history in Oregon runs deep. We have been providing professional liability insurance for 50 years in partnership with the Oregon Medical Association. This partnership has provided a long-standing and sustainable insurance program for physicians and physician assistants. Other companies may come and go, but CNA remains committed to Oregon clinicians to assist you in improving patient safety, to protect your practice and reputation, and to provide education to mitigate your risk. Our insurance program was created by Oregon physicians for Oregon's clinicians. The OMA provides unique oversight of our program via a committee of association members who understand your practice and the challenges that you face. It has been said, kindness can transform someone's dark moment with a blaze of light. You'll never know how much your caring matters. On behalf of all of us at CNA, we want to thank you for your care, your kindness, and your dedication to your patients, and your efforts to improve healthcare for all Oregonians.
Wonderful. I am so pleased to introduce our next presenters, the dynamic duo, Dr. Stewart Decker and Director Jennifer Little. They have an incredible story to share with excellent concrete steps that you all can take to become public health champions in your own communities. Dr. Decker is passionate about community health and collaborates with his local public health department in his role as a family medicine physician and medical director at the Sky Lakes Wellness Center in Klamath Falls. Ms. Little is the director of the Klamath County Public Health Department and has partnered with Dr. Decker to create a community of health in Southern Oregon. Their presentation, Public Health and the Individual Clinician, How Healthcare Providers Can Find Their Way into Community Health, will show us how it was achieved. I'd like to remind people to type your questions in the Q&A box and not in the chat box, and we will be able to get to those questions more easily after the presentation. So without further ado, Dr. Decker and Ms. Little.
Thank you so much for that kind introduction. We hope what we have to share with you today will inspire and encourage you.
So we are here to talk about public health and the individual clinician, kind of focusing on how providers can find their way into community health. When Joy first contacted us about giving this presentation, we were, of course, honored and delighted. And then she told us the lineup, and we were immediately hit with crushing imposter syndrome. After wallowing in said imposter syndrome for a couple of weeks, we realized that what we really have to offer is that we live in a small community in Southern Oregon where our public health professionals, like Jennifer, and our clinicians, like myself, know each other outside of the professional setting, and therefore we're really easily able to connect ourselves in the professional setting. So we have a lot of great experience with coordinating between public health efforts and individual clinicians, and that's what we're here to kind of share with you today. So we can progress to the next. Jennifer, I have no disclosures. Do you have any?
I don't have any.
Solid.
So what we're hoping that you learn today are how to understand public health frameworks and models, what public health professionals like myself need from clinicians like you and Stewart, and what the existing resources are to help clinicians get into this public health work. So just a quick glance, this is a picture of beautiful downtown Klamath Falls. For those of you who don't know, we are a rural community set in the high desert of Southern Oregon. Our county is the size of Connecticut, but home to only about 68,000 residents. Nearly 1 in 5 of our community members are living in poverty, and about half of our adult population lives with a chronic condition. HRSA designated us as a health professional shortage area, and for years, Klamath County ranked at the bottom of the Robert Wood Johnson County Health Rankings. This chronic lack of providers really necessitates the need for strong public health and health promotion programming to reserve physicians for the truly sick. Next slide. So this paints a little bit of a bleak picture, but again, we have some, it's a happy ending. And So after years of being at the bottom of those health rankings, Klamath decided to mobilize. So in 2012, leaders from our medical system, our CCO, public health, and our FQHC formed the Healthy Klamath Coalition. We conducted our first community health assessment and our first community health improvement plan, which really set the stage for health improvement projects through the years. Fast forward to 2019, and we have been recognized for our innovative and collaborative projects. And Klamath was one of 4 winners nationwide out of 190 applicants to win the Robert Wood Johnson Culture of Health Prize. And if you don't know about Robert Wood Johnson and this Culture of Health Prize, it's kind of like the Oscars of public health. So it was a tremendous honor to be recognized for that. Next slide.
So I'm not going to leave this slide up here for long, but this is the criteria that a community has to have in order to win that prize. There's that list of 6 things. You can obviously come back to this when you're reviewing our slide set, but the gist is that these 6 things really fold nicely into those public health frameworks that we're going to be teaching you in a minute. So here is our first learning point, the 2 different public health frameworks we're going to try to teach you guys today. The first is a socioeconomic model, and then the second is the health impact pyramid. That little subsection A, that is policy, systems, and environmental change. What you'll notice, it's kind of a buzzword currently in public health. So if you see PSE written everywhere, that's kind of the big focus for public health currently, is trying to make sure we're focusing on policy, systems, and environmental change, however we are approaching the projects we have. So next slide.
Okay, so Stewart mentioned the first model we'll talk about very quickly is the socioeconomic model. And there's a couple things that we'll highlight. Under here, you'll see yo-yos and WITs, and some people might think, what is that? Well, there are some individuals who feel like you're on your own, a yo-yo, versus some people who feel like we are in this together, the WITs. So it's the yo-yos versus the WITs. And what the socioecological model shows is it's kind of this nesting doll framework that shows how health behaviors and health outcomes are influenced. So at the very core of that, you have the individual, that's their knowledge, their attitudes, their skills, and it works out from there to their interpersonal, their families, friends, social networks. Organizations, maybe it's where they live, where they spend some time. Work out to the community and relationships between organizations. And then on that highest level is public policy at the national, state, local level. And what we've learned through the decades and the centuries is that those bigger bubbles have a larger influence on a larger swath of people, and they are simply more effective. And so we'll really be talking about how you as a physician can move up that ladder and work on more of that public level to get some of the work done. And those higher rungs really focus on that PSE, those policy, systems, and environmental changes. And we'll move along to the next slide, and we'll just give you a brief visualization of what some of this might look like. So on the left, you'll see this built environment that is not the most appealing. And someone who's in that yo-yo category, the you're on your own, might think, gosh, I keep telling this person to go out and exercise and they keep not doing it. Maybe they're just lazy or they just don't care. Not realizing that maybe this is where they're living, not the most appealing, maybe not the most safe. We're in this together, those WITs might consider, okay, if that's where they're living and they're not getting exercise, let's transform where they're living. So the picture on the right is the transformation of the same area, which now is this beautiful built environment that is much more appealing and safe and attractive to people to go out and exercise. And so if you're looking at that policy systems, environmental change, you're trying to focus on how do we get from point A, that not so great picture, to point B, the really attractive built environment. And that's what we'll talk to you about today, as how you as a clinician can help influence those changes. On this next slide, you'll see just another example. These are kind of the classics, exercise and nutrition. So this is a transformation that also happened in a corner store. On the left-hand side, if someone lives in a food desert and people are trying to tell them, you need to eat healthy, you need to eat healthy, and this is all they have, chips and soda, that's going to be a little bit more difficult. It's not simply a lack of willpower, right? But you can see that transformation maybe through a healthy corner store initiative, where now that same space has healthy options, fruits, vegetables, looks like some juices and waters in there.
So in this next slide, you can see that socioeconomic model with the bubbles going up, and we'll focus on the bottom. The individual is what the individual knows and believes. So in this example, we'll go through something near and dear to Oregonians' hearts, again, vaccines. So what the individual knows and believes about vaccines, the side effects, the benefits. So we've all been in those situations in the office working with someone who believes a certain thing about a vaccine, and we're trying to convince them of a different thing. The next step up is where we start encouraging people to think about the interpersonal level. So when maybe what their friends have done, what their friends know, their friends' experiences, their family. That's a location where we can have an influence. Organizational locations, that's churches, churches and schools hosting clinics. A really big deal here is electronic health records at your health system. So just trying to maximize the systems to really highlight if someone needs a vaccine and when. In the community, you have examples of health fairs connecting public health and school boards, PTOs. And then the last thing is policy level. So removing non-medical exemption, changing school recommendations, requiring education in health classes. Those are some examples of locations where we can influence finally that bottom individual's decision, their health behaviors. So on the next slide, we'll move on to the next public health framework. That's the health impact pyramid model. I love this one because that little top triangle where clinicians traditionally have an impact just looks a little more friendly, looks a little bigger. There's counseling education where we're talking to people, teaching them things. There's our clinical interventions, and then vaccines and colonoscopies are long-lasting protective interventions. I think we are all here today because we're a little bit on that yo-yo side, or sorry, that whipped side of that spectrum. And we all kind of want to get to that point where we're really impacting the bottom of the pyramid. So the next slide will just highlight changing the context to make individuals' default decisions healthy, and then socioeconomic factors. So the big question is, how do I get from the top of the pyramid to impacting the bottom of the pyramid? So in the next slide, you'll see one really cool example of a resource. This is the High 5 impact, or the health impact in 5 years, produced by the CDC. So the reason I love that health impact pyramid is because the CDC uses it. The criteria for being included in this website or this endeavor by the CDC is that these interventions have to have positive health impact, results within 5 years, and then cost effectiveness or cost savings over the lifetime of the population or earlier. So if you're someone, and we'll get to where you can be in this spectrum later, but if you're someone who really likes to or wants to get into the socioeconomic determinants of health, but you don't really know what to focus on, you can maybe take a tour over to the CDC and look at the listed interventions that have proven impact. And some of these, one thing I really like to point out on this slide is that some of these are obvious. There is access to clean syringes or tobacco control interventions. Those seem like obvious wins. What I love about this is there's some really not obvious ones. So home improvement loans and grants, earned income tax credits. These are things that have proven effectiveness for positive health impacts and cost effectiveness over the 5 years. So I find that just really impressive. It really drives home the point to me that health is everything and everything is health, which just means that if you are someone who has an interest in biking or an interest in electric cars, you can use that interest to really push for public health interventions within your field of interest. So let's pop over to the next slide. We have now completed Learning Objective 1. We've taught you some public health frameworks. We're going to transition to objective number 2. So what public health needs from clinicians. We'll get to this slide earlier, but a little background is public health has gone through a number of transitions. So in the 19th and 20th centuries, we're really looking at public health 1.0. So this was a period of great improvements. We're talking sanitation, transportation, housing, clean food and water, vaccinations, antibiotics, just huge impacts. And at those stages, we needed clinicians to apply those things. We needed clinicians to give vaccines, give antibiotics. Public Health 2.0, which is the next step, that's the mid to late 20th century. That's when public health started getting organized around specific problems, specific disease-oriented processes. So creating specific programs to address emerging threats and rising burdens of disease like HIV. So you can imagine lots of specific programs for specific diseases. Now we're transitioning to Public Health 3.0. And in Oregon specifically, we call this public health modernization, which Jennifer will talk about in a second. But what that looks like is trying to move public health upstream to not need specific programs for diseases that already exist, but try to work to prevent those illnesses from becoming problems in the first place.
Right. So as Stewart mentioned, public health modernization is a thing in Oregon. So with the passage of House Bill 3100 back in 2015, and then later the House Bill 2310 in 2017, public health modernization is now written into law, and it guides our funding, it guides how we do our programming, ensuring that we have strong foundational programs and capabilities. So if you look on this slide, this is a diagram showing what public health modernization looks like in Oregon. So you'll see across the top, we've got those foundational programs: communicable disease, prevention and health promotion, environmental health, and access to clinical preventative services. So obviously there's a few areas where clinicians really fit nicely into these, and some may be a little more nebulous, but again, we're going to talk to you about how you can start dabbling in some of those more non-traditional programs. And then on the bottom here, you'll see we've got the foundational capabilities. So these are what really support those programs. It drives our work forward. These are the things that we are held to and that we need to do in order to meet the needs of our community. And so the Coalition of Local Health Officials and Oregon Health Authority, we had this framework and we had to figure out, well, where do we start? And thank goodness somebody had some foresight, and we started with communicable disease. And so regions and communities partnered, and we conducted health assessments, and we were able to decide on what our communicable disease work was going to look like based on the needs of our community. And it was this really beautiful relationship that Stewart's going to talk about, of how public health and primary care really married for some pretty cool outcomes.
So you might be thinking, you know what, this sounds a little familiar. We're going to start an analogy here that we'll come back to, but the idea is that public health as a whole within Oregon specifically is at this stage where it's trying to start relationships. It's trying to find the right match for this area, right match for this one. It's going through trying to find programs and individuals who it wants to partner with. Sounds a lot like it is on the single and ready to mingle spectrum of relationships, which to me, it means that we should probably have something like Public Health Tinder. We should have a way in which interested parties can meet other interested parties. So one of the big questions people ask themselves is, how come I am not, how can I get into public health? How can I create a relationship with a public health program? And one of the first answers is you have to be available. You have to update your profile. You have to make public health know, or let public health know that you are interested in having a relationship with it. So we'll come back to that analogy in a little bit, but we're hopefully looking for a public health Tinder that can connect all of our interested parties together. So we'll go to the next slide.
So like we said, public health modernization, we started out with communicable disease. Here in Klamath County, we partnered with Jackson County, and we're really looking for how we can move forward. Part of our project was HPV vaccinations. So I'll let Stewart talk about that process.
Yeah, so the very first thing we did, again, the background is Jennifer and I, and the public health department in general, and I knew each other from my time in Klamath Falls and how small it is. So when the public health department needed a medical champion, someone to really drive home the connection between public health and individual physicians or individual clinicians regarding HPV vaccination, they kind of approached me. So that's always going to be stage one, is the parties need to know that they're interested in each other. I was recruited as the medical champion for HPV vaccinations. And what that looked like for me was partnering with a public health organization, a public health department, to create and edit a train the trainer presentation for how to talk about HPV vaccinations in clinic. And we trained providers, yes, but we also trained MAs and rooming staff and front desk staff and clinic administrators to try to maximize all of the ways we could come at this problem. So rooming staff were addressing the topic with patients as they were rooming them. We were changing the health system in that we took a look at our EHR and we created new templates for well-person visits and new structures for warning or highlighting a patient's vaccine lack or need for vaccination before the provider actually went into the room to see them. So this was an example of a really nicely realized partnership. A connection was made, and then the parties involved went back and forth with new ideas on how to further the partnership, going from training trainers, going to every clinic in town to give this presentation, to then changing the health system and the electronic health record itself. So we'll give a couple other examples of how public health and individual clinicians have worked together in Klamath Falls and look forward to working together in Klamath Falls in the next couple slides.
So we promise you this is our only COVID mention in this presentation, but with this COVID response happening very quickly, it really did highlight the need for this intersection between primary and public health. And hopefully this looked very similar in your communities too, but some of the things that public health really relied on physicians for were things like having standing orders. For example, at a long-term care facility, they needed standing orders for their staff and their residents to be tested. Or for when we had mobile testing sites out in our outlying, very rural communities, we needed standing orders for those. And looking forward, when we do have a vaccine, we're going to need standing orders for those. And so that's a really great way where providers can use their expertise and their degrees and certifications to help further these public health responses. In addition, we relied heavily on our medical community to help with our public messaging. When providers say something, it carries a certain amount of weight and respect because just historically, doctors are well-respected members of society. And so we relied heavily on them to help carry our message. We also, of course, relied on our providers to give those patient notifications. Before we started our case investigations, they helped us with communicating about what to expect and how to take care of yourself while you're in quarantine or isolation. We also partnered with our primary care providers for turning their clinics into testing stations or to help with those mobile testing sites. And in addition, we found that there was a lot of individuals who tested positive for COVID and didn't have a provider. And so we relied on our providers to open up their doors and accept new patients on maybe a faster pace than they would have otherwise. And on this next slide, you'll see, so I said getting away from COVID, that was our only mention, I promise. So another area that is a public health crisis that we absolutely need to partner with physicians and other community-based organizations are things like substance use disorders. And so, for example, particularly in rural communities, we don't have many Suboxone providers, and we need more of them and more of them to feel comfortable doing this kind of work. And so I'll turn it over to Stewart to talk about his experience with some of this work.
Yeah, so I think that this is a great example for the second time this topic is going to come up, which is a medical champion. So some things that I learned from Jennifer during this presentation is that for inpatient treatment for substance use disorders, those locations need an H&P done within 24 hours of intake. I mean, I didn't actually know that, and that's been law for a year. Now, I think that this is a great example of when a medical champion is a perfect solution. So all a health system needs is one provider to know that little fact and then disseminate it out to the rest of the providers. If nobody knows it, or if nobody is designated or has decided to become that medical champion, becomes a lot harder to know those little factoids and then distribute that information. This is, like I said, this will come up again, but the idea is that a medical champion is one of the best ways to partner with public health departments. An example of that is I'm starting to become a Suboxone provider, and it's hard because I am becoming the medical champion for that within like my little clinic area. And I'm reaching out to find out who has done it before in my area and how they set up their clinic and how they set up their system. But my experience really does, like, I have reflected time and time again about how much easier it would be if someone who already knows what they're doing can teach me how to set up my clinic. So I'm seeking a medical champion within my community who can show me how to do this. Otherwise, I'll become it myself. But just really highlights the need for that person to be the intersection between these two groupings of health. So in the next slide, we can see just another example. Jennifer mentioned mobile clinics. In Klamath Falls, we have really rural outlying areas, and we're developing processes with mobile clinics. So this is another way that providers can become involved with public health, is writing standing orders or helping promote or helping fundraise or helping write grants for mobile clinics. In the next slide, you'll see another way that clinicians can intersect with public health, which is within advocacy. So the picture on the slide is our White Coats for Black Lives protest or gathering in Klamath Falls. We spent about an hour over lunch at a corner in downtown having lots of really fruitful conversations. Clearly everyone's wearing masks, which is a great example setting in two ways. Other things you can do as an advocate is writing letters to the editor, offering testimony for specific bills that may be going through the legislative session, calling your senator, calling your elected representatives. So in the next slide, I'm going to summarize this a little bit for you. I just want to remind you that when you are trying to connect with public health as an individual clinician, the very first step is making your interests known. And Jennifer will talk about how important this is, how desirous just sitting with a person and having meetings or getting coffee can be. But the first step is always make your interests known. If you are the most interested person in the built environment, but the people doing the built environment in your community don't know it, you're never going to have a cool project fall in your lap. So what I like to summarize, the way I think about this is that public health needs individual clinicians to be one of two things. You either get to be a medical champion. This can be for any current or future project. This includes the pandemic. This includes specific projects like a needle exchange van or bike trails in your community. This is true for specific populations, the Native population, other disadvantaged populations, or it could be connections to other organizations like community-based organizations that aren't necessarily the public health department proper, but are doing a lot of really good work in the community and could use a little help from a clinician. So option one, medical champion, really big driver for something connecting. Option number two is advocate. So public health needs advocates. This can be community-wide versus organizational. A great example of this on a statewide field currently is the tobacco tax that's going to be coming up on our current election cycle. So physicians advocating for something that is clearly tied to health is a really impactful and important voice. So if you are a clinician and you are interested in being an advocate, things you can do, like we said, you can write letters, you can write editorials, you can sign on to those letters or editorials, you can make calls, you can record messages, all sorts of options for advocating. And the real key for advocating is if you don't know what to say and when to say it, you ask someone like Jennifer, or you say, hey, Jennifer, I'm interested in being an advocate for you. Please tag me when you need something.
And believe me, we will. And so like Stewart was saying, you know, if you were interested in a letter to the editor, but maybe you don't have time or you don't know what to say, we are happy to write those for you. And then we'll run it by you, make sure you're happy with what we're saying, you can edit it, and then we'll even submit it for you. We will make this as easy as possible. And there could be advocacy that happens just within your own organization. For example, Stewart was talking about getting Suboxone providers up and ready to go. Or maybe you want your hospital to become safe sleep certified, and that has to do with passing internal policies and training your internal staff and having a champion to say, we want to promote safe sleep amongst our new families, and here's how we're going to do it. Another really great way that you can indirectly advocate is to recruit your patients who have this lived experience to offer their voices on committees and boards. For example, every CCO in the state has a community advisory council, and by mandate, those community advisory councils must have 51% member representation, meaning those people have to be on the Oregon Health Plan through their CCO on that community advisory council. And something that's been really successful for us here in Klamath has been physicians having a conversation with their patients saying, hey, you would be a really great person to represent, you know, people of your population, maybe in your neighborhood, on this community advisory council. And that means a lot because, again, physicians and clinicians are respected members of the community. And when they say, I think you'd be good, you should represent on this board, it means a lot. And so you can advocate for others to also be advocates, which is really helpful. So on the next slide, we'll have Stewart talk to you about some other ideas. Like he was talking about, it doesn't have to be just public health. There's tons of community-based organizations that have public health influence that you can tap into.
Perfect. So again, I'm not gonna, it's a lot of text on this slide, so we don't need to read through each one, but this is more of a reference slide for you. If you are someone who is really on that WITS spectrum, we're in this together and you're struggling to find a way to make that difference on those bottom pillars of that health impact pyramid, here's some great ideas for how to get connected with either organizations doing things or just some ideas for what you might find yourself passionate about. So you can talk to the OSU Extension Service, which does an incredible amount of work with food, nutrition, and schools. You can call DHS. You can visit your senior center. Jennifer actually sits on our senior center board, which is amazing. One of my favorite things that Jennifer also taught me how to do is subscribe to your local newspaper. That way, every Sunday, you can sit and read and find out what cool things are happening in your community, and it might just spark a little interest for you. It's some article about a program that's happening down the street from you that you didn't know about, but now you do and kind of want to help with. My favorite one is J, which is contact your director of public health. Jennifer can attest to this, but if a clinician calls her up and says, hey, I'm interested in helping with public health, but don't know how to do it, could we have a meeting in which to talk about my interests and what you need? Jennifer, how do you feel about that sort of call?
I love taking meetings, especially coffee meetings.
There we go. So you've heard it from the source. On our next slide, you'll have some other ideas for what you can specifically do for people or do for organizations. The gist is this slide is showing that there's a number of ways that you can interact with organizations. So you can sit on an organization's board, you can join a committee, you can write letters to the editor, write op-eds. These are things that we've talked about before. Again, if you don't know what to do, but are just curious or interested in doing something, this is what Jennifer means by it's okay to be a tool. Your basically capital within the community is your trustworthiness as a clinician. The public loves to hear things from people who they trust, who they believe have their best interests at heart, and people in the medical field just have a really beautiful trust capital. And public health departments can really use that trust capital. So when a letter is written by a clinician, it means a lot more than by Stewart Decker, the individual. So when she says we can use you as a tool, that means that they always have ways to use a clinician, to whether it's just signing on to a grant application or signing your name at the bottom of a letter that you agree with but didn't have to write, all the way to sitting on a board or teaching community classes. Usually organizations like the public health department or CBOs will have ideas for how to use you, the tool, the clinician, to further some of those public health ideas. So in our next slide, we're going to progress to learning point number 3, teaching you about some existing resources and roadmaps. Jennifer, your internet back on?
I think so. Can you hear me?
Yeah.
Okay, great. So you'll see, and I mentioned this earlier in this presentation, but we have community health assessments and community health improvement plans. And so every county that is in Oregon has one of these, I guarantee it. And you'll see here at the bottom that if you have a nonprofit hospital, they have to have a community health assessment every 3 years, dictated by the IRS. Every coordinated care organization must have a community health assessment and community health improvement plan done every 5 years. Local public health authorities, same thing, every 5 years. Federally qualified health centers, every 3 years. Hopefully they aren't all doing those separately. They're called community health assessments and community health improvement plans because they should all be combined. And I think that's happening more and more. But this is an excellent way to figure out what is happening in your community and what has been prioritized by people in the community. This wasn't just one person sitting in an office writing up these plans. These are meant to be collaborative projects. And so if you go to the next slide, this is just one really quick clip from Klamath's Community Health Improvement Plan. This is one of our priority areas that the community said, this is really important to us. We came up with our objectives, our strategies, we have baseline data, we figured out what a reasonable target would be. And so reading over your community's CHIP can help you understand what are some of the priorities, what's the work happening. But in addition, hopefully, and like ours does, it's not on this page, but it also says what other organizations are helping with that work. So if maybe you don't want to get involved with the public health department, but you want to get involved with one of the CBOs that's also helping with this work.
Maybe that community-based organization can get you connected as well. We do have, there's an ArcGIS web page that hosts all of the CHIPs for all of the counties in Oregon. We can have that in some notes for you that you can access. It's just a really long URL, so not a great thing to put on a slide for you to frantically copy down. If you go to the next slide, this is a second resource that we have available to us in Klamath Falls. It's called the Healthy Klamath website. So it is beautiful. I love this website. You can see on the right just a screenshot of one of the opening pages. In that screenshot, I have clicked a button that says join us, get connected with a work group. So you can enter your email address, your name, and then you can see on the left, you can just click on which work groups you're interested in. And my experience with this is I just wanted to test it out. I logged on to it. I'm already on a lot of these work groups, but I clicked the buttons and I pressed enter, and 30 minutes later, I got an email from Kendra Santiago, who is the woman who is monitoring the site, saying, hey, Stewart, you know you're already logged in for most of these, but we're happy to have you. So there, at least in Klamath, this is a really well-utilized, well-resourced resource for you to just get immediately plugged into things that are going on in your community with community members. If you go to the next slide, we have an example of a similar website in Clackamas County. So we perused around Oregon. We were looking for other organizations that had similar websites, and we found at least one, Healthy Clackamas. They also had a Get Involved button. You can see that right there on the right. So perhaps your community has a website like this, or maybe they don't yet have a website like this, and they should. Maybe that's a point where very globally, you can poke your community in the right direction. If you go to the next slide, we have kind of a summary for that last section. This is how to create connections with organizations. So we talked about how to create connections as individuals, how to create connections as an organization. In this one, I'm talking directly to the OMA, OAFP, other member organizations. I just want to point out that you have a ton of members, and a lot of your members are very interested in public health and interacting with public health. Perhaps you could be a touch point for connecting with public health agencies, connecting physicians, connecting clinicians, connecting individuals with community-based organizations. Maybe some interventions that could really highlight that maximization or maximize that interaction is inviting public health representatives to your meetings. Maybe you could be a driving force behind creating a Healthy Oregon website instead of just a Healthy Klamath website. So the question, the ask is, can you be our public health Tinder? So we'll progress to the next slide. I'm going to summarize. Jennifer, welcome back.
I'm so
sorry to
sorry.
have you missed. We breezed beautifully through. We're just at the summary slides now. So the summary, if you are an individual and you're looking to get into public health, I think that you are in one of two positions. You either know exactly what you want to do. You already know what you're interested in. You know that you love the built environment. You know that you are really passionate about tobacco. Whatever it happens to be, your first step is to find the people doing those things, and you can use the Healthy Your Community website. You can use the chip, like Jennifer mentioned. You can use just the internet. You can use your Sunday paper. You can use these resources we talked about, and then schedule a meeting with them. Call somebody up and say, hey, I'm interested in helping. Would you like to just take down my name and number, and then you can call me if you need an editorial written, or I would like to do something more. Can we talk about what are all the things I can do for you or with you? Option two is you're someone who wants to do public health work, but you have no idea what you want to do. You're just kind of lost in the overwhelming situation of just seeing people and as an individual every day. You see systematic problems and you don't know how to make them better. Your steps are, one, look at that chip, see if anything strikes your fancy. There's people doing great work in your community right now, and you just don't know about it yet. You can look in your newspaper, you can look at your Healthy County website, just like before. And again, your next step is to schedule meetings with the public health director and beg them to tag you in. So whoever is doing the work in your community, there's usually someone who knows more about it than you. For us, it's usually Jennifer. Jennifer usually knows all the things that are going on in Klamath Falls public health wise and can just pull those little strings to plug this person in here and plug this person in here. And then lastly, if you're a large membership organization, maybe consider inviting a public health rep to your meetings, be on your board, something like that. It's big change, could be scary, I know, but this is just kind of off the cuff thinking. And then maybe think about exploring becoming public health Tinder, maybe making a statewide website. I don't know what that would look like. I just believe in the power and capability of member organizations to address the needs of their members. And if this is a need of the member, I think that we can try to get that going. Next slide, we'll just wave goodbye.
Yeah, thank you so much, everybody, for inviting us to this presentation. These are some beautiful pictures that Stewart has taken of our community. Please come and visit, talk to your public health directors, and yeah, we just thank you so much for all of the work that you're doing in our communities.
Yeah, you have our emails up there and our phone numbers. Give us a call.
Thank you so much, Dr. Decker and Director Little, for that incredible presentation. You touch on so many important areas and especially give us really great concrete ways that we all can get involved or be involved. I also want to point out that how much I appreciate you talking about the other kind of epidemic in Oregon, which is substance use disorder, and all of the public health and health sequelae from that particular issue that I feel like has somewhat gone to the wayside in our public eye because of the pandemic and some of the other things that we're facing. So I appreciate you touching on that and bringing up the importance of providers being able to care for that vulnerable population as well. So I appreciate your answering questions in the chat so readily, but I do believe we have some other questions to pose. And I will start with this one. Is your public health department planning to get involved around impacts of climate disruption, particularly in the setting of all of the wildfires that our whole state and much of California is experiencing right now?
Yeah, this is Jennifer, great question. And I briefly mentioned in the chat, but particularly in the Klamath Basin, but I know a lot of places around the state struggle with air quality. And so we that's one of our biggest focuses. And certainly with climate change, air quality is going to be an extremely important issue. What we've done so far is we've been really well connected with our Economic Development Association and the Chamber of Commerce, because there are economic impacts of poor air quality, both for tourism reasons, but also for basically EPA restrictions that can be put on businesses. And you need to have a thriving economy to have a having better health outcomes. So our business community does see that connection, which is really great. We've applied for a few grants through national organizations like Robert Wood Johnson to try to do more climate change work. We haven't been successful in that yet, but hopefully in the future we can do more of that work, particularly because it affects health equity in a major way, and we understand that.
This is Stewart. I just wanted to add 2 things to that comment. The first was that one thing Jennifer mentioned was a really big lesson for me, which is that our public health department had to apply for a grant to do some work on climate change, which means if they don't get that grant, it's really hard to do that work. So we mentioned earlier, one of the easy things that clinicians can do to help further public health is be available to help write grants or be a supporter for grants. It's just, I didn't really realize that there wasn't exclusively public funding for public health departments. You also had to write grants to do stuff. And then the second thing that I just always like to highlight when talking about climate change is that there's 2 ways to approach this. You can talk about the profound public health effects that will happen in the future from sea level rise and forced migrations. But sometimes in kind of the current partisan nature or partisan world that we live in, that kind of gets lost in the noise. So one way to focus on climate change is to talk about current pollution and current health effects, including asthma, lung disease, heart disease, and some of the interventions that you can push for to address current problems, current effects, will have those long-term effects that we're really looking for. So that's something that we can partner with public health departments as well, is to really get the word out about current downsides of pollution and ozone, et cetera.
Thank you. I also want to acknowledge just the interruption of your presentation with our sound issues and apologize for that. And I would like to give you both an opportunity to perhaps speak to some of that part of the presentation that was cut off. But before we do that, I really want to go back to something that Director Little said about partnering with the business community. And, that was a question that came in the Q&A box. And I'm just curious if you have any specific examples of how the business community in your neck of the woods has partnered with, you all as public health stewards, or if they haven't, or you don't have any specific examples, what you think might be ways to get our local business communities to really be invested in our public health initiatives.
Yeah, I'll take a stab at this first, and then Stewart, you can chime in. And one thing that I'll point out is that public health work doesn't just live within the public health department, right? I think we all understand that. And so a really great initiative that's happened in Klamath Falls is called Klamath Promise, which is a graduation and chronic absenteeism initiative. And the business community has been incredibly engaged. Like a local jewelry store owner sits on the board of that initiative, and they've done a lot around encouraging students to show up for school. They've literally knocked on doors. These business owners have knocked on kids' doors who have been absent for X amount of days and say, we really want you back in school, because they understand that larger concept of how education affects your health. On the public health side, more traditionally, like I said, we've partnered with the Economic Development Association and our tourism office, and working with them on just a variety of initiatives, whether it's research or, like I said, air quality, wood stove change outs, those kinds of things. And so I don't necessarily know what that looks like engaging businesses in a metropolitan area, but because we are rural, it's very easy to get connected and really get people involved, particularly in the business community.
So two things that I can add. One, Klamath Falls recently put in a protected bike lane. And part of the reason, or part of the way that was approved, was of course all the wonderful health impacts you get from encouraging biking, encouraging connectivity, encouraging just non-auto travel. But one of the ways it was sold to the business community is all the alternative, like the additional benefits for home value increases and increased foot traffic and bicycle traffic along main business thoroughfares. So it does highlight that a business case can be made to businesses for a lot of our public health interventions. As I mentioned in the presentation, I do believe that there is health in all policy, which just means that all policy can also, even things that don't necessarily seem to have a particularly big health impact, we can make a health case for them, but then also things that have a really obvious health impact probably have a business side to them too. The second part is that one thing we're working on right now is a smoke-free like health area. The hospital is kind of located a little bit north and east of downtown, and the goal is to create a 3-block or 4-block area in which it's a dedicated no smoking area. And to get those businesses, because there's a lot of businesses in that several block radius, to get those businesses involved, it's really just direct outreach. Our people, our CEO, our board of directors, our clinicians going to those businesses and asking them personally to participate. I think that very individual connection goes a long way. And then just smoke-free areas. One of the things I've been learning recently in tobacco research is that having a smoke-free workplace does more for decreasing smoking rates than, say, even tobacco taxes do. So really worth pushing for.
Thank you. Those are great examples, and I think whether it's rural communities or metropolitan communities, I think you've given us some really good ideas about how to partner with local business. Another question came in that not all clinicians, so MDs and PAs and nurse practitioners who are seeing patients have training in foundational public health concepts. And so the question is, with the Healthy Klamath Project, was there some workforce development or training available for clinician partners?
That is an excellent question and an excellent idea. No, we haven't done that. And gosh, I think we should just take that. We might steal your idea. Thank you, whoever gave that idea out. But there are a lot of great resources out there for individuals who do want to dabble in public health, maybe learn up on it. NACCHO, which is the National Association of County and City Health Officials, has a ton of really excellent information on there, 101, 202 kind of modules. ASTO, which is the Association of State and Territorial Health Officials, is another really great resource where people can just get some of the basics for that kind of work. And yeah, Stewart, anything else to add?
Honestly, so I'm doing my master's in public health courses right now. So I'm learning a lot of those foundational public health concepts. Also, I know that schools or medical schools currently are, at least my experience with current medical students, is that they're getting a lot more training going through medical school as we speak, which is great. But what I found is, even though I'm going through MPH classes, I am getting some of this foundational public health concepts. A lot of it is great in terms of me understanding what is going on, but I still find that my most productive moments come at the hands of someone like Jennifer saying, oh man, you know what we could really use somebody for? We could use somebody to do this, and kind of being steered or pointed in a direction. And I don't want to kind of diminish people's passions. Like, if you have an idea that no one is doing currently, then man, it would be really hard to do that without foundational public health concepts, to know where to start or how to start a project like that. But again, so often I feel like the times where I have felt the most impactful, it has been partnering with someone who is already doing something and having and them helping me along figuring out in what way I can be the most impactful.
I think you both just exemplify the collaborative nature of public health projects. And it really is, it's really wonderful to even just hear you guys go back and forth about how, how modeling this partnership with folks who are the experts in public health, along with the clinicians who are seeing things day in and day out, is really, can really lead to success. So, so I appreciate that so much. I had a question about, you talk a little bit about how in general clinicians are looked at as people in the communities who are trustworthy and who it's often a really great idea to lend their name and their profession to some of these public health works. I'm really curious about some of the concerns from communities of color and communities that have been disenfranchised and marginalized, and who have a distrust in the medical establishment in general. And I'm really curious about what you have found or have done, or what steps you've taken to help deal with that issue, and just make people feel more able to trust some of the initiatives and things that are coming out from your good work.
Yeah, one of the things that we've done particularly recently and through the COVID response, and I saw there was some comments and conversation in the chat box about this earlier, but the CBOs, the community-based organizations, have really come to the forefront and been our ally. I don't know necessarily what this looks like on the physician end, and Stewart, you can address this, but as far as carrying our messaging, the Healthy Klamath Coalition is full of CBOs. And so we've been able to really use them as our conduit and the bridge to those communities that they're serving, whether it's people with disabilities, people of color, people with linguistic or cultural differences. And so we do rely on people from those communities to be the messenger and to be that bridge. And certainly an initiative that we have moving forward is simply diversifying our workforce within public health in general. And so we've been working on what that can look like, and hopefully too the next presenter can help give even more education on that. But Stewart, how does it look from the physician end?
So there's a lot of ways to approach this. I think that one, with coronavirus, we have a large number of CBOs that are being tasked with contact tracing. And then what we have heard from those CBOs is that a lot of the times when they're doing contact tracing, they'll get a hold of somebody in whatever group that CBO is specifically focusing on, who has questions about primary care, or connecting with physicians, or connecting with somebody who can give them healthcare that they don't necessarily know the answer to. So in that respect, the OAFP, the Oregon Academy of Family Physicians, is trying to help create some training to help teach those CBOs how to communicate about healthcare, about health professionals, to those people that they're reaching with contact tracing. So that's option one, just like Jennifer mentioned, working specifically with CBOs who are addressing those kind of questions and health disparities among their, I guess, participant groups. The second way is we have this idea of really changing the baseline. So I think the example of that protected bike lane earlier was a good example of this, in which it is a change to the built environment that will affect people whether they know it is affecting them or not, whether they kind of are trusting the medical system, the individual clinicians, or not. So I think one other way of addressing some of our health disparities is really trying to dig down to like the really, really roots, where you don't necessarily have to even go into a clinic in order to receive the benefits from having new parks, or having safer walkways, or safer paths to school. But I think Jennifer's point, when it comes to specifically addressing underserved populations, it's working with people who already have trust capital with those underserved populations to develop that relationship first, and then from there kind of gaining exposure to those populations.
Thank you. So I wonder if we might offer so I wonder if we might offer you two a little bit of time to address some of what might have been missed in our small technical glitch. And I'll just open it up to you to comment.
Stewart, I feel like I've been starting everyone. Do you want to start?
It's great. So I think that one of the things that we missed, which I'll ask you to talk about, is just how the public health modernization is encased in Oregon statute and how that affects public health departments. But one of the things that we did miss was an example of our HPV work, the You Are the Key to Cancer Prevention project that we did. This was our first example of someone being a medical champion. Essentially, the public health department, as part of public health modernization, first started focusing on infectious diseases, and within Klamath and Jackson County, focused specifically on HPV vaccination rates. And what they decided they needed was a medical champion to connect with basically all the clinics in town. So I was approached primarily because I had, over the last several years, told the people in the public health department that I wanted to do things like this. And that had resulted in various letters to the editor, radio interviews, phone calls, et cetera. But this was the first big project that they said, oh, you know what, this would be perfect for a longitudinal approach for a clinician to do. And what that ended up looking like is going and doing train the trainer lectures or lunch lectures or trainings at every clinic in town about how to talk with patients and their families about the HPV vaccine. But I think the most important thing that came out of it was this kind of back and forth on systems thinking for how to create a system in each individual clinic that is specialized to that clinic that can help with increasing vaccination rates. And whether that is implementing new training for the rooming staff versus the administration staff versus the clinicians themselves. And then really one of the big swings was changing our electronic health record so that at every appointment, if someone was missing a vaccination, that was highlighted to them, leading to lots of new reports that you could run to call children and their families to tell them that they were missing this, that open conversational doors. It really ended up, what was cool is that the people in the public health department didn't know that note templates and these electronic health record functionalities existed. And then once they had that input from someone using that record, they were able to develop these new targets that really did impact how we approach vaccination rates and improving vaccinations. So an example of how that partnership between a medical champion and a public health department, or in other situations, CBOs or other organizations can really flower because of your different backgrounds and perspectives.
Yeah, and just along with that, when someone like Dr. Decker is able to go and talk about the electronic health record changes, it does, again, carry more weight because they use that tool as opposed to public health saying, you need to implement this in your electronic health record. It's why would they listen to an outsider? So it just worked really well. But like Stewart mentioned before, and where it kind of cut out in the presentation, was that public health modernization was written into law in Oregon, and it wasn't funded as well as we would like, but I think that's the reality that everybody gets when they're asking for money from the government. And so those foundational programs and capabilities were looked at. The Coalition of Local Health Officials and Oregon Health Authority decided, where do we want to focus our efforts first? Because you can't just try to address everything all at once. So we focused on communicable disease, thank goodness, because then COVID hit and we were way more prepared. But moving forward, we are advocating for additional dollars because particularly after the pandemic, we've been seeing how incredibly underfunded public health is. And so hopefully modernization will continue to be funded at an adequate level so we can continue to really build a modernized public health system. And there is a toolkit online if somebody wants to read the whole modernization toolkit. It's up there and gives you a lot more background information on it.
Great. Thank you so much. I think we could probably continue this conversation for a really long time. There's lots of engagement in the chat, and I encourage you and Dr. Decker to perhaps answer some of the questions that have come in the Q&A box. But we do have to move on. Thank you again so much to the both of you for joining us today and for all of the incredible work that you all are doing. I personally am looking forward to reaching out to both of you with all kinds of ideas that are swirling in my mind, and I'm sure that many of our participants are as well. So thank you again for joining us today.
Thanks for having us.
At this time, we are very pleased to introduce Dr. Susan Bailey. She is the president of the American Medical Association, and she is with us with a special message. Dr. Bailey is an allergist and immunologist from Fort Worth, Texas, which you will be able to tell from her lovely Southern drawl when she begins. This year, she was elected to be the 175th president of the AMA.
Hello, I'm AMA President Dr. Susan Bailey, and I send you warm greetings on behalf of everyone at the American Medical Association. This year has tested us in ways few could have imagined. From the COVID pandemic to the wildfires that have swept through Oregon and much of the West, time and again, physicians, physicians' assistants, nurses, and our entire healthcare community have risen to the challenge of this moment. Your tireless work in the face of these extraordinary events has been nothing short of heroic. Some have died. Many have fallen ill. All have worked extremely long hours under intense pressure and in sometimes dangerous conditions. The AMA and Oregon Medical Association are proud to stand by your side. We have been your ally and your steadfast partners from the beginning, fighting to get you the resources, information, and equipment you need to keep yourselves and your families safe. I'd like to thank the leadership of the Oregon Medical Association and its president, Dr. Ewanchyna, as well as Oregon Governor Kate Brown for your state's aggressive approach to limiting the spread of COVID-19. Most of all, I extend my most sincere and heartfelt thank you to you, Oregon's physicians, and to our colleagues around the country whose courage and selflessness have shone through these very difficult times. Thank you.
Before I introduce our last speaker of the day, I would like to take a moment to hear from our final sponsor, Northwest Permanente, for a brief message.
Good morning. My name is Imelda DeConis. I'm an internist and the CEO and president of Northwest Permanente. Thank you so much for this opportunity and for us, Northwest Permanente, to be a returning sponsor, especially for this year with the theme of Medicine Now, Leadership in a Time of Transformative Change. I share with you this picture, 8 presidents and CEOs for the 8 Permanente medical groups across Kaiser Permanente in the 8 states and Washington, D.C., where we operate. Since 2015, for the first time ever, 3 of the 8 presidents and CEOs are women. Now, you and I know health, wellness, and health outcomes come from the conditions in which people are born, live, learn, work, play, and age. Systemic racism, sexism, homophobia, xenophobia, whether it's these or social determinants of health or climate change, we have a voice. We physicians and clinicians must lead. And here's a quote I want to share with you from our recently departed Justice Ruth Bader Ginsburg. Fight for the things that you care about, but do it in a way that will lead others to join you. As this is true in the exam room with our patients, so this must be in our communities and society. Thank you.
For our final address, I am absolutely delighted to welcome Dr. Alletha Maybank, who is the inaugural Chief Health Equity Officer and Vice President of the American Medical Association. At the AMA, Dr. Maybank ensures that health equity is embedded in all of the work of the association, and she will oversee the launch of an AMA Health Equity Center. Today, we are honored to have you here, Dr. Maybank, and for your address, the impact of racism on public health. As a reminder, please type your questions into the Q&A box, and we will have the opportunity to speak with Dr. Maybank after her presentation. Thank you very much.
Hello, everyone. Good to be with you, Dr. Letha Maybank. Thanks for the opportunity to speak with the Oregon Medical Association. It's been really great to get a lot of feedback and kind of excitement for the Center for Health Equity from medical associations across the country. And we at the Center for Health Equity are definitely here, to work to support the associations kind of moving through this process of what it means to really center equity in the work that we do, whether within the context of the association, but also the work that we do in our healthcare spaces. So good to be with you. Next. I have no relevant financial relationships to disclose. Next. And, our goal is, really to discuss the role that we have as institutions in fostering and exacerbating racism and inequities, but also what do we do in order to mediate them and kind of have a path forward in which we can change the existing realities. Next. So I first start off always, I think this is an important part of anti-racism work and centering equity, or centering those who have been most marginalized in this country and often were stripped of resources and opportunities without their input, clearly without their consent. And so really recognize the indigenous people of this land who were here well before many of us, well before the founding of even this country, and for their thriving and surviving to this day. And then also honor and recognize those ancestors who have been brought to this land and who were forced to this land from the continent of Africa for the sake of for free and cheap labor in order to build and sustain our country and our system of capitalism. These are med students in Tulane. This was in 2019. They took this photo in front of a plantation down south to really honor and recognize that they stand on the shoulders of those who have come before them and who have fought injustice for hundreds and hundreds of years. Next. So just to ground us so that we're all on the same page, important to know, this is a definition of health equity. There are many definitions of health equity that are out there. So this is just one, and this is more outcomes-based, but I usually say that in order to have health equity, you have to have the conditions, the resources, opportunities, and power. Power is a really important part of being able to achieve optimal health, being able to achieve a lot within this country. And if you don't have power, if you're not in a position of power or stature, or a state of power within this culture, in this country, it's really hard to achieve optimal of many things. And this is a very simplistic way of defining the distinctions between equality and equity, and really recognize the realities. And our goal is really to remove these structures and barriers that prevent all people from having freedom to live their lives and to be able to achieve optimal health. Next. Important to this conversation of advancing equity is the importance of moving upstream and appreciating public health. Many folks who have heard me speak, I talk a lot about the divide of public health and healthcare. And I think during this time of COVID, it really sheds a light on the need for us to come better together as disciplines and to value and respect what each discipline has to offer to creating health within our communities, but especially public health. I mean, the reality is that we know that health is shaped by many factors and conditions within our society, and our healthcare system oftentimes is focused very downstream in terms of what's happening in the hospital walls and the doctor's offices. All very important, we know this. However, it's very difficult to fully take care of a patient in many parts of this country, whether urban or rural, if you don't understand the context of which folks live. And so it's important that we do understand the living conditions and the social drivers that impact health. It's important that we understand what are the structural drivers and the institutions and the policies and the laws that actually determine what those living conditions are going to be. And then in this country and in any country, we have to look at what are the real root causes of inequities? What are those lenses that are being used to develop laws and policies that are impacting the living conditions? And we have to look at the systems of power in this country, which are really rooted oftentimes along the lines of those that are listed on the slides of white supremacy, classism, racism, sexism, homophobia, ableism, and xenophobia. So this is the full frame of health, and I don't feel we can advance equity unless we understand this and we embrace it. Next. Important to know that this is not work just about diversity and inclusion. There are lots of conversations, and I'm sure many of you have heard about diversity and inclusion. I think there are very important values and realities that we need to have in order to advance equity, but they alone cannot get us to the point of having equity and justice and fairness. We need to move our conversations beyond just diversity and inclusion. As this great quote rather from that was actually published, this was last week in an article, that we first should demand inclusion and power in our programs of, and it could be health or healthcare, if for no reason other than our basic civil rights. Let us stop with the cultural competence and diversity and inclusion jargon, and really name, these systems of power that are excluding folks from these opportunities. Next. We have to understand, to the point I mentioned earlier, also what produces in health inequity. So I talked a little bit before about kind of what's the frame of health, what creates health for us and for us all. All of those conditions are important for us all that I had on the previous graph or two slides ago. But you also need to understand like what produces the inequities, and we have to look at, again, those isms and those structural determinants of health. I really point out on this slide, on the bottom half, it's important that folks understand, especially in the healthcare context, there's lots of use of the word social determinants of health. And I tend to use it less now because it's become very jargony, and it's not well understood. And the reality is that most of what we're doing at the healthcare system level at this point in time is really focusing on the social needs and understanding what are the social risks for people. So we're responding to those immediate conditions as it relates to possibly food or transportation. That's what we're focused on in the healthcare system. We really also need to focus and be able to look more upstream and kind of what is happening within the context of communities in which people live. What are those social drivers that are impacting inequities? And then eventually we have to go even more higher upstream and look at the causes of the causes, as I mentioned before. What is the socioeconomic political context and structures that actually, drive inequities within this country? And as a healthcare community, we have a role that we can play in absolutely all of these levels. Next. So we know that in this country, there are life expectancy differences. So I'm going to move into just highlighting, a little bit of data. I'm not a data heavy person for many reasons, but I want to illustrate a point, is that we have life expectancy gaps between neighborhoods among the 50 largest cities in US in this particular graph. The one with the greatest life expectancy difference is actually Chicago. That's where AMA is headquarters, as you all know. And they have a 30-year life expectancy difference of up to 30 years between Streeterville, which is like the central part of Chicago, and the south side. And it's unbelievable and unjust. And this was happening before COVID even existed. So the question we have to ask is why? And who's living in those neighborhoods? And when you go to look at the data of who's living in those neighborhoods, they're predominantly Black and Brown communities, predominantly Black and Latinx communities, to be more specific. And again, it should highlight that these realities are structural. Something created it, something produced it, why the communities are laid out in this particular way. And the only thing within this country, that can really produce these types of structures are policies, or these types of patterns rather are policies. And policies within this country have dictated where people can live, what they have access to, what they don't have access to, whether their neighborhoods are invested or they're not going to have investment, whether they have good transportations or not good transportations, whether they have to go outside of their neighborhoods for jobs or they can stay inside of their neighborhood for jobs. Do they have good agriculture? Do they have grocery stores? Policies are what dictate this. And the reality is that many policies in our country historically have excluded Black and brown folks out of the opportunities to achieve anything that is optimal, as I mentioned earlier. And historically, the specific policy that really excluded folks and determined where they could live are policies related to redlining, which is the map on the left, which is a very old map, but health inequities kind of overlay even these old maps until this day, in which those red communities, they were actually on policy that said that banks should not back loans for families that live in those neighborhoods because they were considered risky. And so it really prevented Black, brown, immigrant communities from being able to tap into that, quote, American dream that has been put out there. And it's really been more of a myth, honestly. Not everybody has been able to really capture or be a part of that American dream, because if you can't buy real estate within this country, it's really hard to tap into that. So only a certain segment of our population had the ability to be able to buy homes and move out to the suburbs, of why they're so homogeneously white in this country, and everyone else was pretty excluded. So next. And looking at specifically, again, COVID, in terms of a narrative, and I'm trying to kind of break through some narratives about people, there was lots of conversation about early on, the reason why Black, Latinx, and Native Americans were more likely to have and die was because they had these underlying medical conditions of diabetes, hypertension, obesity, and heart disease. But that wasn't really the full picture, as many of us know at this point in time, that, we had to look and understand that the reason why these communities had more COVID was because they had greater exposures, based on the kind of jobs that they have, based on the overcrowding, maybe possibly in the housing that they had, lack of running water in some communities and Native American and Indigenous communities, low wealth, and forces folks to have service jobs. So we have to look at more the structural and social drivers that produce inequities, that set up the conditions that create these higher rates of diabetes, obesity, and hypertension. And the reality is, a good friend of mine says, who's head of the National Birth Equity Collaborative, is that race is not the risk factor here. Race is a social and biological, and race is a social and political construct. It is not a biological construct. And we have to look at the system of racism and the impacts that racism, sexism, all of the isms have on people's health and their lives. Next. And here's just one last map of just showing, of an old redlining map. You can, and that's the kind of the Black, they don't show up so well, but the red lines areas are the Blackish areas on this particular map. And the bright areas of red are where the lowest life expectancy is happening within the city of New York. So you can see that even though, these decisions were made almost 100 years ago, they still have tremendous impact on what is happening within those neighborhoods at this point in time and the access to resources. And just real quick, a definition of racism is that it's a system of power and oppression that structures opportunities and assigns value based on race. It's a very important part of the definition. Structures opportunities and assigns values based on race, unfairly disadvantaging people of color while unfairly advantaging whites. And it really falls along the line of the myth of hierarchy based on skin color in this country. And there are 4 levels of racism: internalized, interpersonal, institutional, and structural. And these systems, and this system has been around for, since this country was really founded, or since colonizers landed on this land, actually. we have had a system of hierarchy and power that has disadvantaged and excluded folks. And I think this is important to understand that really we've been in a country that has been under that lens for hundreds of years. And we've only really been in a new period of legalized freedom, represented by the green part, for a very short period of time. And we all understand that legalized freedom does not really even mean freedom fully for people. Next. And also I think important, in understanding the context of production, and I mentioned it a little bit just a second ago, is looking at the effects really, and this is a global phenomena of colonization and its impact, the lenses of which it brought of power in order to sustain and to build more power and production over time. And so colonization has definitely helped supremacism flourish, as well as capitalism flourish over time. Next. And so many of us, we say that structural racism, and we know at this point in time, is really the fundamental cause and the root cause of why these inequities exist in this country. If we look across the data at health outcomes, the greatest gaps occur along race than any other demographic that exists. And that's why there is such a focus on racism, because it is a leading determinant of health inequities within this country. And it plays out in many different forms in terms of the structures that exist in this country. Next. So in 2018, the American Medical Association, as many of you know, passed policy that was going to create an organizational unit to focus and center our work on equity. Thanks to a task force that was convened over the previous couple of years, that was their recommendation. And in 2019, when I started, Dr. Moderator, as you all know, made this announcement at the annual conference that what has become clear is that inequities that persist throughout healthcare present obstacles to achieving our goals. As a nation and as an association, we need to ensure that when solutions to improve healthcare are identified, the positive impacts are recognized by all, that one shared characteristic of such solutions is that they are also bend towards health equity. So we have been on a mission and lots of action to kind of move our AMA in this direction. Next. So what's been really helpful for me and my team is that Dr. Moderator, who's the CEO, thought through the strategic work and kind of figured out, what does it look like to have these cross-enterprise accelerators, and where does equity sit in all of this? And it's quite clear to all senior leaders and to staff, because this has been communicated quite often now to all staff and the management team, that equity is a cross-enterprise accelerator. If you hit next. Next. And there you can see equity. Next. So equity, is along with innovation and advocacy, a cross-enterprise accelerator across the 3 strategic arcs, but also folks know it's also with the foundational components of the work that we do as well. Next. So we have come and we've created, our vision and mission, and we have 5 approaches of which we are looking to do our work. And we're hopes to have a strategic plan fully kind of launched or distributed later this fall that really will speak to how AMA is going to be centering equity in the work that we do. And so the first one is just embedding equity, and I'll talk a little bit more about that. The second is building alliances and sharing power, ensuring equitable opportunities and conditions and innovation for marginalized and minoritized people, pushing upstream, which I've talked a lot about already, to all determinants of health, and creating pathways for truth, reconciliation, healing, and transformation. Next. So I'm going to speak to embedding a little bit, because I think this is an important part and really where we have to start as associations in the healthcare space. So Alice Walker says, we will be really misled if we think we can change society without changing ourselves. Next. For that, there's an important inside-outside strategy in order to do this work. I do not feel we can do health equity work on the outside or with other folks or in partnership or in our systems if we don't look inside our systems. If our staff don't even understand what equity means, how biases show up in the decisions that they're making, whether it's good intention or not good intention, it's understanding that impact that those decisions can have. And if we don't understand that or how to unearth or know how to unearth that, then we were just going to continue and perpetuate the inequities that exist at the institutional level, which will absolutely have impact in the community and the neighborhood level as well. And so we need to look at all of these internal structures that we have, most of us have within our organizations, and there may be more or others, that impact our policies and our program services and research as well as our culture, and work to change them so that we can have impact. We can become a multicultural racial justice organization that's able to work towards improving health outcomes and closing gaps. Next. This is the model that we're using, and we're working with Race Forward, which is the largest organization doing racial justice work in this country. And we're working with a model of normalizing, building a shared analysis and operating with urgency. Oftentimes, one of our biggest gaps to talk about power and privilege is that we just don't even have a shared understanding of what that is in our analysis, and we can't get on the same page to have these conversations. So it's a lot of kind of capacity building, training, skill building, and then organizing at an institutional level, really understanding where the champions are and where the drivers of change within an institution are, so that we can push forward much faster. And then operationalizing, recognizing that we, one, have to collect data on all the work that we're doing as it relates to this, but also that folks need help. They need tools in front of them so that they can challenge their mental models that they are making on a day-to-day basis. And all of this they have to be able to visualize, and we have to help support. What does it look like? How do we see things that we don't even know exist? How do we know what we don't know? That's sometimes the biggest challenge of doing this work. A lot of this work, and I think I've alluded to this a little bit, is really challenging dominant narratives. So as we're normalizing, we can't do that if we don't understand how narratives shape our consciousness and how we understand and explain the world, and also how narratives and dominant ones can really obscure power and responsibility. That's the point of which decisions are made. Most of us know this, but we don't connect those dots when it comes to talking about health inequities, whether it's by race or gender, sexual orientation, or ableism. That it's about power. Who has the power to make decisions? Who has the power to exclude folks from a conversation or from a decision that's made? Next. And in this country, there are several dominant narratives or myths, you can also refer to them, that undermine health equity. And we hear this somewhat in the headlines, that race and class inequities are unfortunate, but not necessarily unjust. That self-determining individuals make right or wrong lifestyle choices. So a lot of blaming. So that's what happens when you focus, and this happens in healthcare a lot. You focus so much on the behaviors and the risk factors without understanding the social context, what is driving the reasons why people have to have certain lifestyle choices. We totally miss the mark oftentimes of really trying to remedy why a person is getting sick, why a person has a chronic illness, why a person we feel is not following our instructions, because we're placing blame on those lifestyle choices and on the person oftentimes themselves, and not looking more upstream and understanding more upstream of what's not present that will allow the person to make the healthiest choice. And oftentimes those have been rendered invisible, or they're ignored, even if if we look at our own lives, we should understand that when you're in a space of privilege, a lot more, but it really goes out the door oftentimes. There's a lot of othering. We see that in the country today all the time, blaming other people for why they have poorer health outcomes. Picking yourself up by your bootstraps, the meritocracy, the myth of meritocracy. there are many people in this country and folks who have not had the opportunities to live in communities that are resourced and invested. They work hard, and they could work as hard as they want. It doesn't mean they're going to achieve the same amount of wealth as someone in another community that, not saying that somebody else hasn't worked hard, but when you have generational wealth passed down, it is much easier to acquire and to continue to acquire and accumulate wealth in that way. And we know in this country, whites are 10 times more likely to have wealth than blacks in other communities. American exceptionalism also undermines health equity. The zero-sum game, or the myth that if you gain, I lose. And then I already mentioned the hierarchy of human value based on skin color, white supremacy. Next. And what's important about those myths actually is that I first talked to you about kind of the technicalities of how we're going to do the work. So the inside-outside strategy, we have a model that we're employing, we're doing training, we're utilizing surveys, we're going to create tools. But those are the technical pieces of the work, and it's important to do that. But if we don't shift the values, if we don't shift our critical consciousness to understand these values that undermine equity, it's really hard, even with all the work that we do on the technical side, to really advance equity. So part of this work is absolutely understanding and digging into our power and privilege. And this can be based on race, but it can also be just on, you know, incomes that folks have and the stature. You know, being a physician or a healthcare worker oftentimes does create privilege in a way that can disadvantage others without us even recognizing it. So we have to recognize these in many different facets. Next. Our bias and our blind spots. Lots of conversation around biases, especially implicit bias. I'm a person who tends to shy away from saying whether something is unconscious or implicit, because I think, again, or if something's good intent or not good intent, a lot of folks can have good intention and great intention. The reality is that intention, we have to look at what is the impact, because if that great intention has bad impacts, then we need to change what we're doing. And that's what we have to focus on. Next. And we understand there are all these demographics that exist, and identifiers, and ways of being that we all connect to as it relates to race, gender, sexual orientation, language, culture, ability, and age. But when we're talking about inequities, we have to, again, look at the systems that are producing these inequities as well. Next. So we have to reframe and look at sexism, racism, classism, exploitation, ableism, and social exclusion. We have to look at these and assess these and research these systems and how they impact health. So one of the ways in which we have built in accountability, actually really early on, this is, if you look on the left, the whole point of this is that we have what we call performance goals or performance measures. Most staff have them, most employees in different places have them, whether tasks and standards, or we call them APEX. And all employees now have to include health equity work in their objectives and standards. And the performance factors included in everyone's APEX form now will include specific behaviors that support health equity efforts. So for a certain percentage of folks who are really involved in kind of our health equity work group and our action teams, you know, they'll get awarded a little bit more for their participation, and then all other employees will also have a weight for doing health equity. So there's accountability for all employees now to do health equity work, and we're making sure we find and identify those opportunities that employees can participate in. Next. And then lastly, just in terms of the inside-outside structure, is operationalizing, which I mentioned, and the key question is, you know, how do we ensure our efforts and innovation do not discriminate, exacerbate inequities, or deny care? So there are a set of questions that our staff and our teams can ask themselves as they are developing programs and plans, policies, research, systems, flows, quality improvement opportunities, that they can ask themselves as they're doing it, to make sure they're asking all the questions they need to ensure that they're advancing equity, like who benefits from and who will be burdened by the proposal or the suggestion that is put forward, and being really thoughtful and intentional in identifying that and not leaving it to, yeah, you know, I definitely care about this. I care about inequities and all of that, but that could be great, but you could also have unintended consequences because you weren't really specific and intentional. Next. So lastly, as I kind of shift into the next phase of this talk, again, I talked lots about kind of the technical parts of it, but I really like this quote, and I think it's very important because the reality is that we always have to remember that these inequities, the power, the privilege, the racial justice, all, you know, what we're talking about, health equity, many folks can disassociate from the language that we're using, social determinants of health, etc. But we have to always remember, and the last sentence says, you must always remember that the sociology, the history, the economics, I would say the medicine, the graphs, the charts, and the regressions all land with great violence upon the body. And that's the reality, is that that these systems are violent upon people's bodies. They cause stress that's chronic over time. Next slide. They cause stress that's violent, that's chronic over time. That impacts our stress hormones and elevates them, and then further impacts and creates havoc upon the body, leading to higher rates of heart disease and all types of disease. And then even over time can evolve the expression of our genes that can, and this can be passed down across generations. And there is plenty of research and evidence on this. And it's not just racism, but really, again, all the forms of isms that I mentioned before have actual physical impact. Next. And this is why, you know, racism is deemed as a public health issue and why it's a public health threat. It doesn't just happen to the individual, it happens to communities, and it can be passed down across generations. And so this past summer, AMA, as many of you probably know, put this statement forward, that we oppose all forms of racism, that it is an urgent threat to public health, and that we will do and actively work to dismantle racist and discriminatory policies and practices across all of healthcare. A pretty bold statement. And I think what folks are definitely waiting for is to make sure that we all have actions that are going to support a statement such as this. Next. And, you know, I mentioned some of the work that we're doing, but I truly believe that we can't really do this anti-racism centering equity work without really assessing our own institutions' history, present, and practices. And that's in our associations, but also within our healthcare systems that we work in as well. There aren't many systems that are historically white in this country that do not have an experience of which there was definitely power kind of pushed upon communities of which the neighborhoods of which they're serving, that caused, whether it was bad health outcomes or just bad outcomes, and had some negative impacts. And so we really have to dig into what are those things that we did in our history. And so these are, many folks are aware of our exclusion of Black physicians, and then the impact of the Flexner report. Many folks, I in my kind of being at AMA, don't talk about that as much, but there's definitely more push from the outside to really elevate the impact of Flexner. While AMA is, you know, many folks have said it has been a great thing in terms of creating much more rigor among medical schools, feeling that, you know, going towards really structuring basic and clinical science was a great thing. We don't look at the unintended consequences to some level, you know, that when you focus only on clinical and basic science, you've really also, we moved away in medical education from valuing the context of people's lives and the social context of people's lives that also impact their health. And so that needs to be built back into medical education so that there can be an appreciation and value, and then skill set and actions that also support understanding that social context beyond just the basic and clinical science. And then in addition, one of the big recommendations that I don't know if this is intended or unintended, honestly, or unintended or intended rather, but the recommendation of closure of five of the 7 Black med schools actually happened. And so when we talk about the lack of diversity of the healthcare workforce today as it relates to physicians, this is one of the sole and root reasons of why. Next. And this is the Flexner report again. There was a recent JAMA article that actually looked and analyzed in a very interesting way that if those five of the seven were still open, there would be 35,000 more African American or Black physicians to this day, and it would have actually equalized to some level, or at least had better representation of Black physicians within the physician workforce. So we have to look at that, you know, and not only do we have to look at the numbers and the impact, but what do we have to do as the AMA to remedy the harm that we've caused? Next. We did issue an apology, as many of you know, in 2008. And as Dr. Ron Davis said at that time, that this was not the end, that it was the beginning. Perhaps in the end, perhaps it is, but it is perhaps the end of the beginning. Next. And the work that we have to do, that I feel many institutions are now embarking on, is under the umbrella of truth, racial healing, and transformation. This is, you know, I started with the embedding part, the technical pieces, which are important. I didn't talk as much about the other strategies that we have in between, except for maybe moving upstream and the importance of doing that. And now I'm really focusing on kind of the truth, racial healing, and transformation in these last couple slides that I've shared with you so far. But we need to kind of elevate and move to that point in order to really transform our society to this day. And I put this on the Black Panther and Chadwick Boseman, you know, as many of you know, who just passed away, because in order to reimagine a new society or a new way of being, it's going to take a lot of work. And Wakanda, for those who are familiar with the Black Panther, was that opportunity to imagine a community and a society that wasn't colonized, and what would thriving look like. And we are going to have to be able to do that in the work that we do with our healthcare system and in our country overall. And it's difficult because, again, we don't know what we don't know oftentimes. And it's hard to fully imagine what we've never seen. But I think we have to rely on then partnerships and people who have experienced injustice and what they know would be a better life and a better way of living, and how do we have a better healthcare system? People who are impacted most negatively and marginalized by our systems, what to them would look better and be a better system? Next. Oh, and lastly, to close out, talk about our COVID work. Next. We have, you know, done quite a bit. I would say we launched a Health Equity Resource Center, which is online now, has lots of information. We just launched our resource that actually has case examples across the country of different cities or organizations that have been doing work to center equity in their response to COVID-19. We had received a lot of ask and reach out about that, so we wanted to kind of be a central source for that. We're collecting examples every day. We published a paper within JAMA about having a structurally competent healthcare system. So again, moving more upstream, not just culturally competent, but structurally competent and structurally responsive. Lots of information about the missing data and using our voice, which the data is still missing. I just looked at a report from yesterday. So we still have a lot of work to go in that area. And I had the opportunity to talk with Ms. Oprah Winfrey and really highlight actually the AMA Center for Health Equity, but also this work that we're doing on missing data. Next. We launched a prioritizing equity series, which we are really centering the voices of many physicians that often have been marginalized and minoritized in this country, to hear their experiences, but also to talk about what does it mean to prioritize equity during this time of COVID. And it's relevant for COVID, but it's also relevant beyond COVID as well. And this is really, really done very well. I think we've done a good job at really having conversations that are very candid. And so I encourage you all to check them out if you get a chance. It's also on our COVID Health Equity Resource site. Next. And we've been working, so in partnership within Chicago. This past year, for those who don't know, we went into a partnership with Westside United. One of the first times AMA Chicago headquarters has done something of this magnitude in their own backyard. And so we are investing $2 million over the next 2 years, along with 6 other healthcare anchor institutions, to do work and to support upstream work and upstream opportunities that are listed here to support the community. Understanding investment and money and capital are very important in order for folks to thrive and to be healthy. What happened during COVID is because this infrastructure was in place already with all of these different partners and stakeholders, the mayor was actually able to call upon Westside United to start racial equity rapid response teams to focus specifically on mitigation within the area and to identify and listen to resources and needs of the community. We launched also Release the Pressure is a partnership with Essence brand. That's a well-known brand, probably one of the top brands within the Black community. We understood that, and many of you know the data shows that folks were not seeking care during COVID time. And so we wanted to find a way in order to engage our communities to still focus on their chronic health needs, provide information about that, but also provide information about COVID. Next. And so this is the last slide to just, doing this work and centering equity takes a tremendous amount of leadership, courage to do, it's courage to speak, courage to listen, courage to be uncomfortable in ways that you may not have been before. And if we're really committed about it, we have to have that experience. And it's really important at this time that we all kind of speak up, use our voice, use our power in meaningful ways that help advance equity and figure out how to do that. Thank you.
Thank you so much, Dr. Maybank, for that incredible presentation. As a fellow Chicagoan who went to medical school at University of Illinois, Chicago, I feel a bit of kinship with you and some of your slides and your perspective. So thank you very much. One of the slides that really resonated with me was in the beginning of the pictures of equity next to equality. I actually have that pair of cartoons hanging on my refrigerator door, but I hadn't ever seen the two that were paired with it, which are the reality and liberation. I think your presentation really charges all of us to move beyond the superficial recognition and really look for action to change that reality so that we end up in that area of liberation where there are no barriers left. So thank you very much. We have several questions that have come in. And so we'll spend the next little bit going through some of those. I think I will start with this one. This comes from a member of the audience. As a white male physician, can you offer helpful ways to enter into conversations with my patients of color to discuss health and equity without the impression of sounding and acting paternalistic?
Thanks for the question. So how I would start that is, I think part of this is just demystifying to some level that we're unable to have conversations with people from all different backgrounds. I think oftentimes we become fearful. There's maybe certain levels of anxiety that people feel because we haven't been having this conversation, or even people haven't been challenged in this way. So there's some assumption that for some reason we as individuals and as physicians wouldn't know how to speak to people. And I really want to demystify that moment, because we talk to our friends and our families all the time, and we know how to connect with them, usually in very meaningful and helpful ways. Most of us do. And I think we just have to approach people in that same way. with a certain level of curiosity as we're listening and we're talking to people and we're asking questions to just learn more and express, I'm just want to learn more. You know, I don't fully understand possibly, you know, all that you're experiencing. And I want to make sure that, you know, I as a physician is really understanding the context, and maybe not use the word the context, but the situations, you know, within your life that will help me treat you better as a physician. You know, and that opens the door, you know, and then you ask explicitly, you know, so have you had experiences, you know, lately with any kind of discrimination or racism, or if there's something else going on, you know, with anything related to that person's identity, and just kind of opening the door, but also sometimes being a little bit more pointed and explicit, because we know it does have direct health outcomes for the individual in terms of stress. And I think that's how we approach people. That's how we approach building trust, and just really affirming another person's humanity. That you ask the questions, look at them as a human being, and treat them as such. And then you won't come off, to me, from my perspective, as paternalistic. If you go into that mindset, then you will. If you go into the mindset that something is wrong with that person, or even just pity on that person, you know, oftentimes we can enter a conversation not in the right way. And so that's my suggestion on how to approach those conversations with our patients.
Great, I love that. Approaching with curiosity, just to discover. One of the things that you said is one of your slides was about the kind of the false narratives, and you know, these narratives that are perpetuated and that you describe also as myths. And so I'm curious how we as clinicians and providers in the community, how can we help change the shape of some of these narratives from the people that we are seeing in our clinics and hospitals and other healthcare settings?
Yes, I think first it's, you know, understanding more in depth what those narratives really mean and how they play out in our day-to-day lives, whether it's in the context of the healthcare environment or within our own daily lives. And they show up the same, we just use different language, different words, whatever. Or the root is the same, let's put it that way. So I highly recommend checking out, so Dr. Kamara Jones talks lots about the 7 myths that exist that prevent us from ever advancing equity. So I think I mentioned it in the slide deck, you know, of the technicalities that we need to do, but then what's really kind of the value piece that we need to change. So I recommend reading that. And then I recommend really a large part of this work initially, I think for many of us, is that kind of capacity building around knowledge, so that we can begin to build the skills. But you can't, it is really hard for me to tell folks exactly what to do unless you really understand the analysis behind it. And so I recommend books like Cast is a new one that just came out by Isabel Wilkerson, which I'm sure it will win her another Pulitzer Prize. It's a really wonderfully written book. And it really just basically states and does some comparison between amongst the Holocaust as well as India, and stating that we in America have had a caste system from the beginning of time when colonizers landed on the land. So, and it just does a beautiful job at framing all of the contexts of kind of white supremacy and all the forms of oppression, and really rooting it in that the structure around power. And I think when we start to understand that, then there are so many things that kind of open up to us, because reality is we don't know what we don't know. And that's what this work, you know, initially is really pushing for us to see those things that we never really saw before, so that we can appreciate and we can actually do and create and do things differently. It's hard to do things differently if you see things exactly the same. And so we have to push ourselves so that we can change and push our own mental models of how we come to work every day. And so I really recommend as physicians to just really start building that knowledge base. You know, we talk about building knowledge bases with everything else we do, so we have to do it with this as well. And so medical apartheid, which I had, I think, in that slide deck somewhere as well, and is another really just kind of eye-opening book. I was talking to a fellow AMA member the other day that I provide some mentorship to, and he said he was reading the book, and he said he had to stop reading the book because it's really, it's pretty graphic, you know, and it's just pretty horrific to kind of hear kind of the medical community's relationship with people who were enslaved in this country. But it's powerful for him to really get rooted in not only just the knowledge of it, but almost the heart of it. Like, it's hard to move away from the heart. It's just like seeing the public murder of George Floyd. You know, that moved people in a different kind of way.
Yeah. You know, hearing you talk about those two books in particular, and you mentioned the importance of bringing this awareness into medical education, it seems like those two books should be required reading for every medical student, among many others. So I really appreciate that very specific kind of call to action.
Yeah, and I sit on the AAMC now has a committee for equity, diversity, and inclusion. So we're some other folks that you all probably have heard their names if you're into the equity and diversity space. But we're on a committee looking and creating, standards and competencies for medical education, as well as residency and physicians as well.
That's wonderful. We have time for maybe 2 or 3 more questions, maybe only 2. There's so many good ones here, but the shifting gears a little bit, the National Association of Physicians in part started to put focus and support for Black and other non-white physicians because of the treatment by AMA. And so the question is, are there discussions now between these and other physician organizations serving other clinicians of color to do a better job of collaborating and doing so collegially?
Yeah, so that's exactly the second strategy that I mentioned, the building power and sharing alliances in ways that we haven't before. And it's completely acknowledging the strengths and the assets that the National Medical Association, the National Hispanic Medical Association, GLAMA, you know, all of the organizations that are there. How can we better work with them so that our partnerships are more meaningful, and meaningful meaning, shared decision making, et cetera. And some of that, you know, may mean as AMA, who's a little bit more resourced than many of these organizations, that we're willing to share our power in terms of resources and financial resources as well. And what does that mean and how does it show up? So that's, you know, we're thinking through opportunities as that, but I think it's absolutely critical that we have partnerships with physician organizations that even also are not even in the fray or like in the usual kind of suspects per se of organizations that are engaged in leading in medical or organizing around medical medicine rather. There are other organizations that oftentimes don't get elevated or don't get as much attention that I think is really also important to connect with as well in this country. And then we're working also with the Federation. So clearly we're, you know, in communication with the medical societies, but also the other physician associations across the country. And we work very closely with AAP and AAFP, and the plastic surgeons have reached out for us to, you know, speak with. So it's, you know, and, you know, I smile because, you know, I just, sometimes we don't think that, you know, well, that's my bias. So I recognize that as my bias, that surgeons would be fully engaged and interested, but they're human beings as well and have been moved by all of this. So it's been just really pleasing to see how many folks have reached out, you know, across the physician community to get more information and to learn more and to figure out what to do and how to do it best moving forward.
I know we are close to running out of time, but I do want to just give you the opportunity to answer one more question, which is, you talked about making change on the outside and on the inside. And I'm sure that there's people in our audience today who are really curious to hear your advice about what are the 1 or 2 things that I, as an individual, can do to help move all of this forward?
Yeah, I think what I mentioned before, thanks for the question, about just one, learning as much as you can. Because you get comfortable talking about this context to our society and life, the more you embed yourself in it, as with anything else. You know, I can't say, you know, maybe 10, 13 years ago that with an institutional setting that I would be fully comfortable with. I have to get my charger, hold on, sorry. My computer's gonna die. I don't want that to happen. I wasn't fully comfortable, you know, when I first started doing this work to say racism or white supremacy in all audiences, but I'm very comfortable in doing it so because I practice it so often, I do it a lot, but I also know the facts behind it. You know, it's our science and our evidence that leads us there. And so once we really start to understand that, then we gain comfort, and we need to have that comfort, because if you don't have that comfort, then it's very hard to speak up when you're in meetings or your environments and you do see something wrong. You kind of can get uncomfortable to speak up because you're like, I don't have the language and the words behind it. I don't know how to talk about it. So I think those are the two things that we need to do, is learn and then be able to speak up about it, and then be able to act, you know, and you can figure that out not by yourself, but other people who are allies and accomplices, you know, in your space and in this work. And so lean on each other within your systems and organizations to do this work collaboratively.
Great. Thank you so much for joining us today. I really hope that our paths cross again.
Yes.
And I wish we had more time for questions, but we appreciate you taking the time today, and hope you enjoy the rest of your weekend.
All right. Everything. Thank you, and same to everyone else. All right. Bye.
Thank you. So that brings us to the end of our annual conference. I think we did pretty well, considering that it's the first time we've ever been virtual and streamed, and did so with relatively few technical glitches. So thank you all for joining and for staying with us today for our leadership in a time of transformative change. I think what stands out most about the speakers today is their call to action. And I think that perhaps you who are listening may be called to help build a new system of healthcare that is more compassionate and equitable, or it could be working within existing institutions and structures to bring about significant progress in addressing unconscious bias and racism. Some may feel called to connect with your local and state public health officials to build partnerships that will improve the overall health of all of our communities. Or finally, the call may come in the form of advocacy and urging our legislators to bring forth much needed and lasting change. I began this conference by offering that we are in a time of transformative change. It's a time that calls for all of us to step up and become leaders. Each of you have the capacity to guide us into a more healthful and equitable future. And we hope today's presentation and speakers will inspire you to take the next step in transforming your professional and local communities. And remember what Dr. Decker and Director Little said, that health doesn't just happen in the doctor's office. It happens all around us. So thank you again for your time and participation today. Please note that we will send you a message about CME, and please do fill out the conference survey. Your feedback is really important to us, especially in this new platform. And finally, we hope to see you back for the Oregon Medical Association's annual conference in 2021. And we genuinely hope that we will be able to be in person and see each other face to face as we have in years past. Thank you very much, and goodbye.